Xin chào. Good morning, ladies and gentlemen. I hope that everybody is having a wonderful morning. First, let's us take a moment to reflect our journey that we've made together. The insight shared, the knowledge gained, and the connection made. Everything have been remarkable moments. And to help us revisit these moments and carry forward to the momentum, I would like to invite Dr. Grace Brizuela. Dr. Grace will provide us with a recap of yesterday's highlights. Please come to the stage, Doctor.
Good morning. Hey, it's only Dr. Ken awake this morning. Good morning, everyone. Okay. Hi, Professor. I was given a very tall task of summarizing, giving you a recap of what happened yesterday. Very tall order for a very full scientific agenda yesterday, combined in just 20 minutes. So I'll talk as fast as I can. So as introduced, I'm Dr. Briswell. I'm Grace Briswell. I'm from Beatrice as well. Having some responsibilities in JANS. JANS is Japan, Australia, New Zealand, and emerging markets as medical implementation portfolio lead. So programs that are attached to any of our important therapeutic areas, we help implement in country. So that's basically me, and this is us yesterday. I wonder where some people are, but yesterday, this was the view from here. So we had countries from Singapore, we had representations from Singapore, Malaysia, Thailand, Sri Lanka, Vietnam, India, and the Philippines. We have 40 esteemed speakers giving their inputs, knowledge, and helping us really improve on management, primarily for CV, pain, and today also on mental health. We have, again, with the 40 speakers, there were around 140 delegates, which in the afternoon we divided between pain and CV. And there are 50 of us, those wearing white shirts. We're all from Beatrice. Some are not wearing them, but yeah, there's a lot of us really collaborating and engaging with esteemed doctors so that we all together move forward towards better healthcare. So how this is the task to give a recap of the 2 days, and I will try and attempt to do that in few minutes. So this was our agenda. We had plenary session in the morning, we had breakout session in the afternoon, and we had a final plenary session in the afternoon again. And yeah, so I have chosen at least one slide, something that came out or jumped out of the discussions of our esteemed speakers yesterday. So the day began with Professor Ken Hartigan Go giving us a perception of NCDs across Southeast Asia, 2024 insights. So you would have seen in his presentations, most data are, or all are, yeah, most data updated up to, global and regional data updated to as much as 23, 24 statistics. And he did provide a very good micro and macroeconomic level view of the burden of NCDs. And in his presentation, the conclusion was that the burden of NCD is huge and the cost of inaction is estimated to be 7 trillion USD. So therefore, the time to act is now. So that was the call to order. Yesterday, there is an urgency to act, as he has shared that the journey to SDG will bring us nowhere closer to the 2030 target. So that's why Beatrice is here, and that's why Beatrice is engaging with healthcare professionals such as yourself. So in his presentation, we heard the public health perspective of NCD risk factors, which goes beyond the usual modifiable and non-modifiable risk factors that we are all familiar with as doctors. So in Dr. Ken's presentation, he gave the genetic, environmental, government, patient factors, what are the others? Genetic, environment, social demographic, of which education is the most critical determinant, factors of self-management, where patient decisions on his own healthcare actually figures, and lastly, the medical factors, which is what we are most familiar with. So having expanded our view on NCD risk factors, Dr. Ken gave us this million-dollar question yesterday. Therefore, who owns the NCD burden? And I think after hearing his lecture, we all would agree that health is everybody's business. Okay, so it's our business in Viatris Pharmaceutical Agency, and it's most definitely your business. And us moving together would definitely at least help in some way in reaching the goal that we are all aspiring for. And then we move to the very interesting lecture of Professor David Ong-Hing Yui on the gut microbiome in cardiovascular disease and pain science, a journey outside the gut, which was really, really very interesting because it has expanded our view of cardiovascular disease and chronic pain and the factors that affect how the disease progress and even the way medications act on our body system. He has some discussions on that as well. So this is my favorite slide of his presentation, where he did say that the gut microbiome eubiosis maintains health, and any dysbiosis in any of the systems would therefore impact health, creating disease, and also the way we respond to medication. So interesting field in the science of gastroenterology, and therefore this again calls for collaborating between other fields of specialty. And then we move to the very interesting, again, lecture of Dr. Yutain Norana on the neuroscience of patient compliance. So having prepared in my past roles many modules on patient adherence, patient compliance, we have always bucketed the reasons for non-compliance into patient factor, physician factor, and health systems factor. It has always been the way lectures on patient compliance have been presented. But in his lecture yesterday, I'm not sure if Dr. Yutain is here, but really I thank him for even widening the patient factor, the reasons for non-compliance. And in his neuroscience of patient compliance, this is my favorite slide. My pre-medical course is psychology, and therefore this is really very interesting for me. But he did mention that the decision to follow information from environment and social conforming really depends on this ventromedial prefrontal cortex. And this VMPFC is influenced by OFC, now I'm forgetting, the orbital frontal cortex, okay? And then together, they do determine how patients respond. And the sad part is the combination of this seem to respond more to negative narratives. And so maybe, and I think our medical colleagues doing nudges in Malaysia would very much, find this very relevant, that maybe the very flat health education materials that we're providing may not really be effective, but it's the negative narrative that really may bring them to action. And in Malaysia, we do have very good evidence of that in action. And the morning ended with Professor Sean's lecture on leveraging AI for healthcare transformation. And I think this is my favorite slide in his lecture, where he did mention that, okay, fine, we can actually continue the way we are, where most healthcare services may be non-AI approaches, but we can also try to do an AI approach in healthcare with these advantages. It's more personalized, it's more predictive. However, there are concerns and challenges, okay? Whereas the non-AI approaches would definitely depend heavily on patient trust, but it does have limited scalability, and it's always time intensive. And therefore, if we are to move to the 2030 SDG goals, maybe really a look into AI in healthcare or application of AI in healthcare may be worth investing into. And these are some current applications of AI that he has shared with the team yesterday. And then we proceeded with the afternoon CV plenary breakout session with Prof. Chi from Malaysia, giving us a shifting health trends in Asia. And I got two highlights from his lecture where he did emphasize the role of socio-cultural transition and the focus that we must put on diet, physical activities, tobacco smoking. He did give us an idea that doctors, we can do as much only at individual health concerns, but there also has to be some population level health policy making that has to be enforced. But at the patient level, us physicians can do a lot on educating, promoting lifestyle changes, and definitely initiating therapies earlier than the way we're doing now. And then we move quickly with the excellent, as always, lecture of Professor Landsberg on closing the gap in addressing clinical challenges in early cardiovascular management in primary care. So how do I recap his lecture? Very excellent lecture. These are my top 3 takeaway. And because we're focusing on primary or moving towards primary prevention, I think these 3 things that he has emphasized. So in the afternoon, we kind of centered more on one aspect of cardiovascular, which is dyslipidemia management, and really trying to make an impact just by doing our best in this aspect of cardiovascular disease. And therefore, he did remind us that an ounce of prevention is worth a pound of cure, because the first event is fatal in 40% of cases, meaning 4 out of 10 patients would probably die in the first time that we are only discovering that he has an ASCVD. And if only we can bring that number down, I think we're doing our job. And the biggest hurdle about the fear of how low can it go, he did simplify the way we should be thinking at the physiologic level of LDL, which is simply 50 to 70, and there has not been any evidence that going lower than that gives detrimental effect to the patient. So, and he reminded us that while science is there and science tells us what to do, guidelines tells us what we should be doing, but registries would always reflect that we're not exactly doing what science and guidelines will dictate. And so I think the call to order is only if countries can have their own registry so that we can have a look at what we're doing, because up to this point, not a lot of countries would have registries, I think, at a national level. Maybe hospital registries, medical society registry, but not really a national level registry. And then we were taken to a very nice panel discussion, but by no less than Professor Apichard, another favorite speaker and KOL in the region, very excellently navigating the discussion on how do we approach roadblocks along the patient journey in cardiovascular care pathway. Admittedly, the 45-minute session was not enough to discuss all the roadblocks, but I think the emphasis yesterday, at least in the discussion, were more on really roadblocks in treating. In the whole healthcare pathway, we were aiming to have like the screening, the diagnosis, the treatment, and the adherence, but mostly the discussion was really still on treating. How to improve treatment of dyslipidemia, how do we improve the way we prevent ASCVD from happening. And we got a good view from Philippines, Singapore, and Malaysia in the discussion. And our Singapore KOL, Dr. Tam, generously shared what's happening in Singapore, the way primary healthcare systems is being improved to benefit the majority of Singapore population. And then a very crisp, short and sweet and clear lecture from Dr. Hafiz, I hope I'm pronouncing it correctly, from Malaysia. So he lectured on ASCVD. What was his topic? Sorry. Okay, but he lectured on what was stopping or what was slowing the progress in ASCVD prevention. And I just picked 2 or 3 slides from his lecture because I think it's a good reminder of both the importance of the magnitude and duration of LDL exposure. And therefore, this calls us to act earlier and to act more aggressively and more intensively, because this is how it is impacting ASCVD outcome. The cumulative exposure is really directing cardiovascular outcomes. And so if we are to improve on it, on the ASCVD events, we have to start earlier and we have to do it more aggressively. This is a slide that he flashed, but because of time, he did not have time he did not have the chance to elaborate on. But I think this is a very thoughtful slide. He gave the barriers and he already suggested strategies to address. He wasn't able to elaborate on it, but I think you would agree with me that these are all very practical recommendations from a clinician's point of view, very much achievable. And so we can do all of this in our own end. And last lecture for that day, for the CV panel session, the group was debunking statin myths, clarifying misconceptions. And I think these are the critical points that was discussed yesterday. Yes, numbers are important. Yes, going lower is important. But why hesitate moving from moderate to high intensity when we know for a fact that statin pleiotropic effects are real and dose dependent? So if there should be nothing that should prevent us from being confident in moving from moderate to high intensity. Statin remains to be the foundation of lipid management, and he challenged us to tell him what our roadblocks are in doing treatment, and he had a very good slide on the many potential reasons why we won't do it, why we won't escalate the dose, but at least we had time to just discuss muscle side effects, liver enzyme elevation, and the new onset diabetes. And in all these 3 points, he excellently gave scientific reasons on why this should not be preventing us from giving the therapeutics that the patient should be receiving to benefit from CV event reduction. But his most important reminder to me, which is we should all be remembering, is that patient has the ultimate responsibility for his or her own health. So we can tell him everything, but at the end of the day, it is his responsibility. But our role is making or enabling that responsibility. We need to empower the patients to make the right decisions. And if we ourselves are not aware of the science behind all of the therapeutics, then we are doing a very poor job in empowering our patients to give or to do or to make healthier choices. And this is the last panel discussion. We had it was a very full stage here. We had representation from Thailand, Vietnam, Malaysia, and Sri Lanka. In both discussions, I think this was an East meets West, and Professor Apichard was challenging that he was giving his vision that hopefully in the future it's going to be West meets East, and that can only happen if more and more researches and more outputs could come from the East, so that West can find time to listen what East has to say. Because right now, and like what we heard from Dr. Mubarak yesterday, there's no local guideline, but they're really benefiting from the European guidelines, getting good recommendations from these international guidelines, and putting them in their own local context. In Malaysia, we heard that while they're doing Framingham risk score in risk assessment, they're doing the European guideline in treatment. So it's really getting the best of both worlds, trying to do your best in getting the best from these guidelines and implementing them in practice. And this was the last slide. Last lecture on the economics of health, a nudge in the right policy direction. So I really loved the program yesterday, prepared by Dr. Ann. Where is Dr. Ann? By the way, if you haven't met Dr. Ann, I think you should find time to, we should find time to introduce Dr. Ann. But her program, at the end of the program really was, it's like an envelope. So we started with, a wide perspective on NCD, and we ended with the economics of health, where again, Professor Ken Go gave us really challenging thoughts that we should be bringing home when we go home. So there are market failures in healthcare system, and there's a lot of things that is bringing about these failures. But at the end of the day, again, individual healthcare decisions tend to be emotional. So we can only do so much, but let's not underemphasize that so much, because we can only do so much, but that so much is still a lot. But at the end of the day, the patient still has the say. But he did give us a very good introduction on not just the behavioral science that's now developing on how we can impact patient behavior towards the right decision if we only make use of these behavioral nudges, which is really based on scientific evidence anyway. The loss, fear of fear of loss, aversion to loss, okay, and wanting to be in the social norm or aligning with the social norm, all of this, or removing the frictions in healthcare decision making, all of this put together can help us craft programs that would most potentially impact patient behavior at the end of the day. So a nudge is a useful tool for policy improvement, especially in the health domain. And so, yeah, so, and he also have this reminder that while now we are empowered, we know nudges, but no one nudge fits all. Just to share, the nudge that we are doing in Malaysia is different from the nudge that we are doing in South Korea. And hopefully we can do several other nudges in other regions as an initiative, as a medical affairs initiative. So, yeah, so I hope I was able to wrap up day one in this short time, and welcome to day two. Thank you very much.
Thank you so much for your highlight, Dr. Grace. Next, to understand about optimizing post-MI heart failure care, guidelines for early initiation and proactive management strategy, it is my honor to welcome Professor Alexander Mebaza to join on the stage. Please welcome, Professor.
Okay, should I stand here? I think I'm tall enough.
Hello, everyone. Happy to be here. I'm sure you enjoyed the evening,
Although apparently there were no fireworks yesterday around the bridge, but it's a lovely city. What I'm going to do in the next minutes is to walk you through what is today the 2024 vision on heart failure. And many of us were in medical school many years ago. Heart failure was really the thing that was left at the end because there were no treatment and patients were dying. And basically it's for palliative care. And in fact, in the last years, things changed totally with totally new drugs that are saving lives. And more importantly, you will see that we found a recipe to even improve even more the treatment of heart failure. And as you will see in a minute, heart failure today kills more patients than many cancer, but there are ways to treat heart failure and not leave behind cancer therapy. And you'll be surprised to see, by the way, that many of the slides I'm going to show you and studies are from 2023, and some are even from 2024, just to show you that really heart failure is moving a lot, and the last guidelines of European Society of Cardiology are really also from the last months and years. Then here are my disclosure. The first thing that we did, I was honored to be part of the task force who wrote the ESC guidelines for heart failure. The first thing we did is to change the definition of heart failure. For years, even if you go to Wikipedia, by the way, today, if you go to Wikipedia and you ask Mrs. or Mr. Wikipedia, what is the definition of heart failure? You'll be surprised to see it's written heart failure is a decrease in cardiac output. And this is totally wrong for those who are measuring cardiac output in patients coming with a huge pulmonary edema in the emergency room, not breathing well at all. In fact, cardiac output is preserved. The problem is not cardiac output. Most of the problem is congestion. Congestion is defined here as elevated intracardiac pressure. And in fact, what it means exactly, it means that upstream the two ventricles, the right and the left, upstream the two ventricles, there is fluid, there is blood, there is a higher pressure, and this limit the flow going out from the organs like the kidney and the liver. Then you will hear me saying many, many times that indeed, if now we clearly understand that heart failure is congestion, we are going to see not only how to remove congestion for a few days, but how to stop congestion to come back forever. And one of the big push that we had in the last years is to have 4 classes of drugs, that one on the top of the other ones, and this is very important to understand that we need really the combination of the 4 drugs. The 4 drugs today are recommended to be given together. The pills should be given together to every patient every morning at the maximum dose. And you are going to see this slide many times because this is the chemotherapy for heart failure, as you may have heard about chemotherapies for cancer. Then the objective today to save your patient, and I will show you data in a minute from our group, showing that you can even stop patients dying for a year or so if you give the 4 classes of drugs, ACE, ARNI, this is to inhibit the RAS system, beta blocker, SGLT2, that is inhibiting the glucose to enter back in the body, and mineral receptor antagonist. If you give those 4 classes of drugs separately every morning, 4 pills, ideally at the topest dose, then you will markedly improve survival of your patients. Now, for years, we were focused on the cath lab, we were focused on acute coronary syndrome, and we were right. But let's look on the figure of 2024. In 2024, we are still putting a lot of energy to describe how is the best treatment to even decrease even more the mortality of acute coronary syndrome. But see here, in the worst case scenario for acute coronary syndrome, the mortality is 5 to 6%. And when you look now on the mortality of heart failure, even if the mortality of heart failure in patients who are at low risk, it's high, much higher than anything in acute coronary syndrome. And see here the mortality of heart failure. We are talking about 40%, between 20 and 40% per year. Today, there are not so many cancers where the mortality is still 20 to 40% in the first year. Then really, our objective, and this is what I'm going to show you in the next minutes, is how are we going to succeed to treat our patients with a mortality that is as high as 20 to 40%, way above anything we can see with acute coronary syndrome. We have the chemotherapy. As I told you, if we take the 4 medications, the 4 classes of drug, we give them at the topest dose, we will see incredible benefits. We will see a marked reduction in cardiovascular death and hospitalization, whatever the cause of hospitalization. This is impressive. All the guidelines, whether they are coming from Asia Pacific, whether they're coming from Canada, the US, they are telling us, please use those 4 drugs, but more importantly, they are telling us, use them at the topest dose, at the highest dose. If you don't give the 4 drugs at the highest dose, you will not succeed to improve outcome. And here is the paradox. Here is the paradox. If you give the 4 classes of drugs at the topest level, you will improve survival by more than 8 years and markedly reduce readmission. But are we using those drugs at the topest drug? The answer is no. Let's start with the United States of America. Here, it's a survey done in the US. 1% of the patients have the 4 drugs at the topest drug. This means that today, just before the election of a president of the United States of America, 99% of heart failure patients in the US do not have the 4 drugs at the topest dose. Okay, but you may say, France is doing better, Germany is doing better. No. Among all the European countries, it's not 1%, it's 2 to 3%. 97% in Europe of the patients do not have the right chemotherapy for their cancer. They don't have the right treatment for heart failure. And when you enter into details, you see that even among the 4 classes of drugs, some are definitely less giving than others. MRA, 2/3 of the patients, they don't have MRA. And even if they have MRA, only few have the target dose. And this was a turning point. This is a study named Strong Heart Failure. And in this study, what we did is we tried to go away from all what we are teaching every morning in the medical school, saying that you should start slowly, the treatment of heart failure. And we said, we have to be aggressive. We have to give all the medications and to find a way to be safe. And by doing so, here is the high-intensity care arm. As you are going to see in a minute, we gave the classes of heart failure, we give them at a full dose as much as we can, and we could markedly reduce in a very short period. Here you see within 6 months, we can already markedly improve survival and the rate of readmission. How did we do this? By giving the drugs at the highest target dose. This is an example of what's happening in one of the countries here, Taiwan. They contacted me and they told me, you know, we are doing very well and would like to compare our data to your data in STRONG. Let's look STRONG. Here is MRA, mineral receptor antagonist. Here is the high-intensity care arm, where you see for MRA, we had almost 100% of the patients treated with MRA. And here the red dark, you can see that almost all the patients had the toppest dose of MRA. Here is Taiwan in green. Taiwan, only 35% of the patients had MRA, and very few percent, like 5–6%, had the target dose. Was their mortality different from STRONG? The answer is yes. As you can see here, Taiwan had a mortality rate that was even worse than the usual care. Then clearly, we should give not only all the medications, but we should give them at the toppest dose, and this was published recently in an American Heart Journal. Now, heart failure, usually the story starts when patient comes with an acute heart failure, and when they come with an acute heart failure, we usually rush to the emergency room or to the cardiac ICU, and we try first to stabilize this patient. Those patients are not breathing very well, and then we give them diuretics, we give them oxygen. And after a few days, the patient will stay in the hospital, and often they are discharged at day 7 to day 10. This is the usual scenarios all around the world. But what we discovered is that there is a window of opportunity between day 3 and discharge, where the patient is walking in the corridor, discussing with the nurses, discussing with the medical students. But in fact, we are not using that opportunity to start the medications. And in fact, this is exactly what we did in STRONG. In STRONG, we felt that we should use that opportunity to start the 4 pillars, to start the medications of heart failure. And you will see in a minute with one of the analysis of STRONG, if you start the medications of heart failure before the patient leaves the hospital in a safe environment, then you will be successful 6 months and more later. Now, why should we start the treatment before discharge? Because conversely to what we all think, the patients leave the hospital and he's still congestive. If we ask cardiologists taking care of those patients coming in acute heart failure, and we ask them, when the patient leaves your ICU, are they congestive or not? The answer is indeed no. And by the way, it's written in my medical report. I did a great job and the patient left the hospital without any congestion. In fact, we are wrong. See here, at least 1/3, at least 31% of the patients leave the CCU, leave the hospital, and they are still congestive. And since they are still congestive, when you are going to send them back home, indeed, they are going to face what we name the vulnerable phase, meaning that the patient, after a few days, few weeks, is going to do a new pulmonary edema. And we know that every new pulmonary edema will lead to death. And this is really horrible with patients with a high rate of death after the vulnerable phase. And we know today that during this vulnerable phase, heart failure kills more patients than many, many cancer. And this is a paradox because, again, we have the great therapies, but for years, the patient was going back home without any treatment. He was doing a new pulmonary edema, and he was dying. Then the challenge here is how are we going to introduce as quickly as possible, at the highest dose possible, the oral heart failure therapies and try to see whether this will really decrease the rate of death and readmission. And more importantly, I think this is what the STRONG trial would not have been possible many years ago, because the treatment would take maybe 1 year, 2 years to act. And today, we have a treatment that acts very, very quickly, and I will show you data in a minute. We know that SGLT2 inhibitor, we know that ARNI, we know that eplerenone can act rapidly, and I will show you data in a minute showing that really within few days, in fact, those drugs can translate to benefits. And indeed, because we gave all those medications together before discharge and we up-titrate after discharge, we could end up having this striking improvement in survival and in readmission. Then what do we mean by up-titration? Here in STRONG, you will see the data split by the classes of heart failure therapy. Here you have ACE, ARNI, here you have beta blocker, and here you have MRA. In small blue, you have the usual care arm. Those are the patients who were sent to the cardiologist in town. And in purple, you see here the patients who were treated by the investigators. And you can see that at week 2, but clearly 3 months and 6 months after beginning the high-intensity care arm, half of the patients, you see that in the control arm, we are talking about 1 to 2% like the American study CHAMP. Here in STRONG, half of the patients had a full dose of ACE and ARNI, and almost half had a full dose, the highest dose of beta blocker. Again, you should remember that those drugs were given together every morning. Then the patient had every morning a full dose of ARNI, a full dose of beta blocker, but the most impressive results is here. See, more than 80% of the patients in the high-intensity care arm, where the cardiologists were really pushing the fires, high intensity, the highest dose means for eplerenone 50 milligram, and you see that 3 months and even 6 months after discharge from an acute heart failure episode, more than 80% of the patients had a full dose of eplerenone. Then you have to understand that those patients, 3 months and 6 months after discharge, many of them had the full dose of ACE-ARNI, a full dose of beta blocker, and the full dose of eplerenone. And it's because they had the full dose of those drugs that this translated to a benefit in survival and in hospitalization. Now, in those patients in STRONG, you can say, but only 50% had, for instance, the highest dose of a beta blocker, and this is related to the phenotype of the patient. In many patients, there were de novo patients with a minimum of comorbidities, no kidney dysfunction, and in those patients, we could go up to the full target dose quickly, safely, without any problem. Already week 2, after discharge, they had all the 4 pillars at the highest dose, at least all the pillars at the highest dose. However, on the other hand, we also had patients with advanced heart failure, kidney dysfunction, liver dysfunction, already some level of hypotension. And here, STRONG succeeded to give the maximum tolerated dose, which is already translated in improvement in outcome. Then again, when you understand that every morning the patient had a full dose of each of the pillars, you understand why we had a so huge improvement in outcomes. Now, I told you one of the secrets of STRONG, and this is now applied in many centers and likely slowly anywhere in the world, one of the secrets of STRONG is to start to give oral heart failure medications before discharge. Those drugs should be given before the patient quits the hospital. Why I'm saying this? Because these are the data here. This was published in JAMA Cardiology a few months ago. Here you have the 3 category or classes of drug, ACE, ARNI, beta blocker, MRA. Here is before discharge, before the patient quits the hospital up to 90 days. And you see for MRA, for instance, you see here, as you saw before, that more than 90% of the patients before discharge were getting MRA before quitting the hospital. And you see that almost all those patients 3 months later had also MRA. Then it's very important, and this is true for the two other classes of drug. You see when they start here, the same patients get the medication 3 to 6 months later. Then it's very important before the patients leave the hospital that he understands that he needs to take the pills, the 4 pills, including diuretics, which makes 5 pills, before leaving the hospital. They need to understand that oral heart failure therapy needs to be given before they leave the hospital. If they do so, then you see that most of the patients get it there. And I think it comes back maybe to what you said earlier on a negative messages. Here, clearly the investigators were saying to the patient, if you don't take the medication before you leave, you will not take them later and you will die. And you see we were successful because really the adherence of the patients was rather remarkable at 3 and 6 months. Now, we understood that they had to have medications before they leave, but why should they take the target medication? Why should they have the target dose, the dose that is described in the guidelines, 100% of the dose? Because if they don't take the highest dose, they will not benefit from those medications, at least not as good as if they had the target dose. And again, we come back to the cancer. In cancer, nobody will give half of the chemotherapy for a cancer. I think we will all do everything to have a full chemotherapy to treat the cancer. And here is exactly the same. Here you see all-cause mortality or heart failure readmission, and here we have a pure survival rate. And see here, only the patients who got between 90 to 100% of the target dose for the 3 classes of drug, ACE, ARNI, beta blocker, and MRA, only those ones had a striking improvement in all-cause mortality and heart failure readmission. And you see here for all-cause mortality alone, you see that even in the first three months, patients getting between 90 to 100%, you see that there were almost no death in the first 3 months, where people are saying if you give the drugs at a high target dose, there is a risk to have a safety concern. There is no risk of safety concern. In fact, if you give the drug at the highest level, your patient will immediately benefit from your therapies. Now, all those data were put together in the recent guidelines. You may have seen this addendum 2023 of the European Society of Cardiology, saying today, any heart failure in the world admitted with an acute heart failure, with a huge pulmonary edema and edema in their legs, all those patients should have an intensive strategy of initiation and rapid up-titration of GDMT. And here you can see black and white, it is said you should start all those medications before discharge, and you should up-titrate aggressively during the follow-up visits with the target of doing everything within 6 weeks after discharge from hospital. Now again, it comes back that the only way to help your patients, the only way to have your patients surviving is to give those 4 classes of drugs and to give them at the highest recommended dose. Now, among those 4 pillars, indeed, there is MRA. And as you know, eplerenone is the most studied MRA today in the world. Eplerenone was tested many years ago in the study Emphasis, that, by the way, was stopped early because of overwhelming benefit in the eplerenone arm. And already many years ago, they were giving us indications to do a strong protocol, because in this trial, they gave 25 milligrams as a starting dose, and within 4 weeks, more or less like strong, within 4 weeks, they said you should up-titrate eplerenone to 50 milligrams. And interestingly enough, few physicians, few heart failure specialists remember that this study included patients from Asia, patients from different countries in Asia, and you see that this also was tested in Asian patients, and the benefits was also seen in Asian patients. Now, this is the primary endpoint, and as I'm sure you remember, there was a striking reduction in cardiovascular death and readmission in the active arm compared to the standard of care arm. Now, those benefits were also seen individually in every secondary endpoint. All-cause mortality was reduced, heart failure readmission, readmission from any cause, and all-cause. For any of those secondary endpoints, there were benefits. As you all know, I was telling you before that what the patient hates is the vulnerable phase, because they know that they come back to the hospital, and when they come back to the hospital, they are even more dyspneic than before, and they may die. And eplerenone is having an incredible benefits on those readmission. It's dividing almost by 2 the risk of readmission. Then really, eplerenone not only is going to improve survival, but also is going to improve the rate of readmission. I told you earlier, eplerenone is the most studied MRA today in the world. Why? Because first they did many subgroup analyses. And one of the subgroup analyses here is elderly. You see that even in elderly, no problem at all. The primary endpoint is markedly improved. They also tested diabetic patients. You know that diabetic patients may have a different pathophysiology, and this is not true for eplerenone. Here with eplerenone, the active arm was markedly effective. And this is effective regardless to the treatment of diabetic patient. And I think this is important because we may hear people saying, but maybe it depends on the treatment. No, in diabetic patients, the primary endpoint is consistently improved. And maybe more importantly, you can see here patients with renal impairment. We also hear many times for all MRA and for eplerenone in general, maybe patients with an impaired kidney function, we can have a different results. The answer is no. Really, even with kidney impairment, we have a very effective drug with marked reduction in mortality and readmission. Now, I think the message, because I think it's important sometimes, and we are going to come in a minute in comparing eplerenone to other MRA. Eplerenone is really the drug today that was tested in all heart failure subgroups, and it shows consistently benefits. Now, in Asia, this result is very important because in Asia, the main cause of heart failure, and I was lucky to visit few countries recently, but I'm participating to studies in other countries, and in almost all the countries, the cause number 1 of heart failure is acute myocardial infarction. Then a study on eplerenone in heart failure after myocardial infarction is so important in this region, and you see here that in this study clearly, here again, eplerenone was associated with a clear improvement in the primary endpoint, here again cardiovascular mortality and readmission, and you see that this is true for every of the different items. And I would like to spend maybe a little bit of time in this slide. Why? Because I told you for strong was beneficial because we used drugs that are acting quickly. And for many people, the heart failure therapies needs 1 year, 2 years, 3 years to be active. See what we can see here. Here, eplerenone works in very few days. See here on the y-axis, we have here all-cause mortality. On the x-axis, we are talking about 30 days. 30 days after starting to give eplerenone. And this is just unbelievable. You see here that within a month, there is a clear statistical reduction in mortality. Then you better understand why in STRONG we put all the 4 pillars together, we gave them to the patients, and why we had a so quick improvement in mortality and readmission. In the last 2023 guidelines of the European Society of Cardiology for ACS, you see it's written black and white that mineral receptor antagonist, meaning eplerenone, is recommended in patients with acute coronary syndrome with ejection fraction below 40%. Then, indeed, we can wonder whether all the MRAs are similar. The answer is no, because as you know, as I told you, eplerenone was tested in all heart failure subgroups. But more importantly, we know that eplerenone has no gynecomastia associated with its use, even at the highest dose. However, we know that spironolactone has, if you use it at the right dose, has 10 times more gynecomastia. I would like to show you some new data, and you are going to be, I guess, happy to learn this, is hyperkalemia. You know that a lot of people are talking about MRA, saying MRA is associated with hyperkalemia. I'm going to show you in a minute some tricks that we found in many centers in Europe to try to prevent hyperkalemia with the use of MRA. First, in STRONG, we saw that there were less hyperkalemia than expected, despite combining all the drugs. But more importantly, we are learning in many centers in Europe and also in the US that combining SGLT2 inhibitor to MRA may reduce and even prevent hyperkalemia. Let me show you the data here. And these are really very, very recent data. This paper came out in Circulation 2 years ago, showing that SGLT2 inhibitor used in the patients who have the highest risk of hyperkalemia. Those are diabetic patients with kidney dysfunction. And see here, in all those studies, almost all those studies, at least if you combine them, you see that the risk of hyperkalemia is markedly reduced. But please pay attention to this meta-analysis that just came out a few months ago in European Heart Journal. In this meta-analysis, they combined 5 large trials. At the end, they had almost 22,000 heart failure patients, 22,000 heart failure patients. Now, what did they do here? What they did is they compared patients with MRA alone, like eplerenone, and patients with the combination MRA-SGLT2. MRA was associated with hyperkalemia, no surprises. You see here, mildly increased hyperkalemia and severe hyperkalemia. However, and this was a big surprise, and I will show you in a minute that it makes sense, to the big surprise of the people who analyze those data, if you combine SGLT2 to MRA, you can prevent hyperkalemia. And as you can see here, if you combine SGLT2 to MRA, you have no statistically significant, neither mild hyperkalemia nor hyperkalemia. And this is likely related to at least 2 benefits of SGLT2. One, we know that there are more potassium coming out in the urines with SGLT2, but maybe more importantly, and this is really what I see in my practice, is patients with SGLT2, heart failure patients with SGLT2, are improving their renal function. And today, SGLT2 is the only drug in heart failure that is improving kidney dysfunction. Then very likely, by improving renal function, by improving tubular function, we are improving potassium metabolism, and we are markedly reducing the rate of hyperkalemia, at least in this incredible and beautiful meta-analysis. You clearly see that combining eplerenone at the highest dose and SGLT2 at the highest dose, you can go around the hyperkalemia. And then the reason why I'm telling you this is because this scheme here has to be rethought and has to be maybe teach differently to our medical students, our residents, and our fellow. Until now, everywhere it was written that we can give a full dose of MRA in patients when the kalemia is below 5, and when we approach close to 5.5, we should decrease MRA, and even we should stop it when the potassium is high. And this is a big mistake, because as I'm going to show in a minute, if you reduce or if you stop MRA, you markedly increase the mortality of your patients. It's exactly like chemotherapy for cancer. Would you reduce the dose of chemotherapy for cancer if the patient has a cancer? It's exactly the same scenario here, and I will show you data in a minute. My recommendation, my 2024 recommendations is please do not stop MRA. Please do not stop MRA in patients with heart failure, and rather add SGLT2 inhibitor or, in very few cases, potassium binder. This means that really today, if you put a patient under MRA, like a eplerenone at the 50 milligram, please add immediately SGLT2 inhibitor, and vice versa. If you have a patient with heart failure and a high dose of SGLT2 inhibitor, please add MRA. Now, why I'm saying this? Because we published a few years ago with top heart failure specialists in Europe, we published this analysis of almost 10,000 patients with heart failure, and this comes from the European Society of Cardiology registry in heart failure. And see this. Here, we analyzed the risk of death. Then what we are talking about here is not hospitalization and death. We are only talking about death, really the strongest and the heaviest endpoint. And you can see here that, by the way, hyperkalemia is not so much associated with death, but what you see here is really incredible. If in the first year where you put ACE inhibitor, because the patient has a heart failure and you start ACE inhibitor, in the first 12 months, if you stop ACE inhibitor, you increase by 13-fold the risk of death. Let's look MRA. Maybe it's different. Here is MRA. If the first year after starting the MRA, you stop MRA for any reason, including hyperkalemia, if you stop MRA, you increase by sevenfold, sevenfold the risk of death. Then basically, if you start ACE or you start MRA and you stop them in the first year, in fact, you are pushing your patient to die quicker. And what is really incredible is here, you see that you better not start ACE or you better not start MRA because the risk is lower. Then really, you should by no means, you should stop those drugs when they are introduced in patients with heart failure. And really my recommendation, if you see potassium going high with MRA, please add SGLT2, and in few cases you may have to add potassium binder. Then ladies and gentlemen, I hope I convince you that today there is really a new way to save our patients, that mortality in heart failure can be markedly reduced by giving the 4 pillars, ACE, ARNI, beta blocker, MRA, and SGLT2, and give them really at the toppest dose. Don't try to stop in the middle, try to push as high as you can. And we could demonstrate this in STRONG. If we give the maximum tolerated dose, if we give the high target dose with a maximum of pillars with heart failure, we can markedly reduce mortality and markedly reduce readmission. Now in heart failure, in strong heart failure, we discovered something. You remember I told you the patient comes with an acute heart failure, and in fact, I can tell you what is happening all around the world, is the patient get diuretics, go back home, he comes back after 2 weeks, we give him diuretics again, he will go back home, he comes back after 2 weeks with, again, pulmonary edema. Then the patient is in fact doing congestion, decongestion. And what we discovered with STRONG is if you give the oral heart failure therapies, you can markedly reduce decongestion forever. And this is what we described in the first presentation in Lancet, is that in patients with a high intensity care arm, our first surprise is to see that they had less diuretics than the patient in the usual care. And we could also see that within the first 3 months, all the parameters of congestion were improved. Then giving oral heart failure therapies markedly improve decongestion. This paper came out a few days ago in JACC, and in this paper, we looked at a relationship between the target dose of the heart failure therapies and decongestion. In this paper, published a few days ago, as I told you, we have here in the x-axis, we go from 25 to 100 of the optimal dose of GDMT, and basically the patients here were the patients who had ACE, ARNI at 100% of the target dose, beta blocker at 100%, and also MRA at 100%. And here on the y-axis, we have a congestion score. Basically means pulmonary edema, NT-proBNP, leg edema. And you see here there is a straight relationship, a direct relationship between the target dose of heart failure and the decongestion. Then not only you are going to improve readmission, survival, but your patient is going to kiss you and say, thank you very much, because he's going to be decongested and decongested forever. Then this is my last slide, ladies and gentlemen, and thank you for listening, and I hope to have some questions. Just to tell you, if a patient comes with an acute heart failure, he's raising the red flag saying, I am not well treated, I was mistreated for years and years. Please, after the first few hours and days where you are going to give me diuretics and non-invasive ventilation, this patient should benefit before leaving the hospital of the introduction of the GDMT for heart failure. My proposal is to give a full dose of gliflozin, to give diuretics, and give half of a dose of ARNI, beta blocker, and eplerenone. And after discharge, please, within the first weeks, you should see the patient and do all what you can to put this patient on full heart failure therapy. Thank you very much.
Thank you so much, Professor. Now we will have a discussion together on the heart failure management. What can we learn from each other? With our chairman, Professor Alexander Mebaza. Our panelists will be Dr. Phạm Minh Tuấn from Vietnam, Dr. Kenerick Chen from the Philippines, Dr. Lim Chun Pin from Singapore. Please welcome.
Let me stay here, please. Sure. I guess we are supposed to discuss but also getting questions from the floor. I hope I was provocative enough. Then what I would like to do is maybe if we can introduce ourselves, and we start with our local colleagues.
Thank you so much for your kind presentation. Of course, you are appearing here. That means a very good chance for us to learn something from you. And Dr. Lim and Dr. Chen, thank you so much for being here. Of course, Da Nang is a very nice city, but even me, I rarely have a chance to visit here in this kind of season. It's very beautiful. But we are discussing about a very, very complicated situation. You know, after listening to your talk, I mean, I don't have anything to say to you. If we can do like what you're saying. Of course, we are under teaching that if we can push our effort to have 4 pillars of heart failure for the patient before discharging, it is great. It is really a good benefit for the patient and for the healthcare system, I think. But I don't know whether in Da Nang City Hospital, is there any doctors or nurses appearing here or not? But I think it is a very good chance for everybody, cardiovascular physician to listen to what you have saying. Yes, I introduce a little bit myself. I'm Tuan, Dr. Tuan from Hanoi. I'm in Vietnam National Heart Institute, and I'm working in the position of General Secretary of Vietnam Heart Failure Society. And I'm very surprised with your presentation and very impressive. And I have something to discuss with us, and we can share our situation. Several years ago, I have a chance to visit Dr. Lim's institute. I was very impressed by that visitation. You know, the flow of the patient. The patient in hospital before discharging assessment and outpatient clinic following, and up titration of the heart failure drugs. I think it's a good flow. But anyway, in my country, it's not like that. I'm working in a general hospital. I mean, the topical in the Hanoi University. Then it is very challenging if you can keep the patient in that flow. I mean, you can see the patient, you can control the patient, and you can up titration the drugs yourself. Of course, it is very easy, but the system, if it can work like that, it is really complicated for only 1 or 2 or 3 clinical doctors. I think we need something more. Our institute make a plan that we will organize a heart failure clinic and control the patient of heart failure trouble. But something I still need some sharing from your country and in Singapore or in your Philippines also. And we are planning for organizing in each city, we can have 1 or 2 HF clinic to manage the patient, because in a localized hospital is different system. In the hospital of the general hospital, it is a different, and outpatient of the private hospital is different, and in the community hospital is different. I don't know whether in your country or not.
Yeah, I think, thank you very much for your introduction, because I think it sets the scene. What I heard is we are 3 physicians, we cannot change the whole country system. Dr. Lim, you are going to introduce yourself and you are going to tell us whether protocols can help or maybe it's an illusion.
Thank you for the introduction. Hi, good morning to everybody. I'm Chun Pin. I'm a heart failure cardiologist in Singapore. I'm currently in private practice, but my background is that I was practicing at the National Heart Centre of Singapore for more than 10 years before coming out to private practice. I would say that the heart failure clinic or the heart failure management journey wasn't a simple one. It evolved over more than like 15 years from my predecessors. Actually, there was David Sim prior to me, and before David, there was also Dr. Bernard Kwok, who first kicked off the first heart failure clinic in Singapore. So it kind of evolved over 15 years. So I don't think it's an overnight kind of development. It comes with a lot of sweat and toil. I think my predecessors worked harder than me, and I only had to like improvise during my time, and so there are lots of things, lots of pieces to put together for it to become a smooth flow. I think when it first started, when Bernard had to fight for funding, and he only had 1 heart failure nurse to keep him company. And then now at National Heart Centre, we've got 14 heart failure cardiologists, just heart failure cardiologists, and we've got about 6 heart failure nurses over there. So and in fact, we also have some cardiology specialists trained pharmacists to help us. So lots and lots of work. So not an overnight journey. Yeah, definitely.
Yeah, thank you very much. And I think we will come to this later. The heart failure nurses, the pharmacists are so important. And in the last HFA heart failure meeting in Lisbon, I was co-chairing late-breaking trial with Mariel Jessup. And many of the late-breaking trials were run by nurses. For example, diuretic dose was given by nurses. And Mariel Jessup, the former president of AHA, told in the whole room with more than 1,000 or 2,000 heart failure specialists, she said, I believe now that nurses are taking care of the heart failure patients better than the physician. Then we should see how the nurses can help. Dr. Cheng, you have also an incredible experience in Philippines, and I'm sure you can elaborate even more
on how are you helped by the other by other disciplines, and really we should go away from what we heard. You are not alone. You are not alone. It's a team. It's a teamwork.
Yeah, that's very correct. No, in fact, we're now entering a very exciting field in the management of heart failure. I would remember probably 30 years back, we're just limited with diuretics, beta blockers, ACE inhibitors, ARBs. And when a cardiologist manage a patient, we'll just say, "I'm giving you everything already. Unfortunately, we have to deal with the consequences of mortality." Nowadays, we do now have a lot of new drugs and devices, interventions as well. No? So that's why I said it's exciting, but at the same time, challenging. Yesterday, we were talking about roadblocks for the management of lipids, dyslipidemia, and I think there'll be double or triple roadblocks we face, especially for heart failure. But in terms of multidisciplinary team, well, for Singapore, you already have 14 heart failure specialists. Well, in the Philippines, we have
14
5.
in the whole country, maybe.
The whole country. In one center, sorry. 14 in one center. We have 5 for the whole Philippines.
But you can hire people from Singapore.
Yeah, we'll recruit. So we have 5 advanced heart failure specialists for a country with 120 million people. So, but it's something, it's a small step, but we're going there. We do recognize that maybe a primary care physician or even a general cardiologist will not be able to manage this, I would say, complicated heart failure patients. And we do now need the help of the other specialists. For example, of course, interventional cardiologists, cardiovascular surgeons, heart failure nurses, pharmacists, electrophysiologists, wherein they put in some devices, CRTs, and so on. No? And with the evolving other specialties like cardio, oncology, we do see a lot of heart failure in these patients, in this population, as well as nephrology. Dealing with the hyper-K, maybe I'll just make that recommendation you made. No? So our nephrologists will be very easy in terms of just adding SGLT2 and potassium binders and so on. So it's actually a multidisciplinary team approach. You know? And I don't think just a general cardiologist or even the primary care physician will be able to deal with these types of more complicated heart failure patients.
Yeah. And again, to try to make a team around you, in this part of the world, there is, we said earlier, a lot of myocardial infarction, but also a lot of diabetic patients. How do you interact with the diabetologist? Because, I mean, they have their own culture. Now we are, by using SGLT2, we are interacting, or at least have a common medications. And I know in many countries, still the connections between heart failure specialists and endocrinologists is not perfect. And how would you see this in Vietnam? I mean, would you see that you are going to teach a little bit more heart failure to the endocrinologist, or how would you see that we better improve the management of those patients?
Yeah, Professor. Actually, you know, multidisciplinary program for heart failure patient management, it's very important because not only the diabetic or endocrinologists, but also the doctor from rehabilitation center, I mean nephrologists, and anywhere. We have, in my institute, we have a big, you know, condition, very good condition, that like my hospital, it is a general hospital, then we can discuss with them just by one phone call. It is very easy to make a phone call like this, and we can make it very popular. That is how we can organize a team with the diabetic doctors and nephrologists and rehabilitation, and some doctor from nutrition center also, and some mental disorder center also. But how to develop it into a model that can be make it national. I, that is why the VNFS, we, I know we've found it 2 years ago.
Mm-hmm.
And we want to develop that kind of model in whole Vietnam centers.
Okay.
Yes, of course we know the the SGLT2 inhibitor indication and contraindication, of course, but sometimes the young doctor, whoever that don't know about that benefit and the discomfort of the patient when we use that, they have to discuss with the endocrinologist, of course.
Yeah,
That's
very
your
good.
suggestion. Of course, we have some benefit because the big hospital, we have many kind of
Sure.
requirement.
Yeah.
But in some, like Institute of Cardiovascular only, they can work as an interventionist or cardiovascularologist or CCU, something like that. They don't have any idea about other fields. Then it is quite complicated to make, the discussion like that, and very difficult to have a consensus about what should they do with some kind of nephrology disorder, like endocrinology disorder. And that is how Vietnam National of Heart Failure Society was organized 2 years ago, and we want to make it, because I think this is the decade of heart failure. Recently, 10 years, heart failure, many study, many kind of, breakout trial was open, and we can have a lot of benefit from that.
Yeah.
Yeah.
Dr. Lim, there is an elephant in the room, the general practitioner, the primary care physician. In some countries in Europe, the Social Security do not reimburse the management of heart failure patients if it is simple and it's taken care by cardiologists. The cardiologist should take care of the complex cases and to try to remove the more simple cases to GP. Is this happening in Singapore? And would you see it's a way to have more patients treated? How would you, can you elaborate around that?
Yes, so you're absolutely right. With the growing population of heart failure patients in the hospitals, the number of patients in each of our clinics is really just bursting. And if we kept every one of these heart failure patients, or even the stable coronary artery disease patients in the system, in the hospital system, then it becomes untenable and it becomes unmanageable. So we have recognized this, and we try to decant some of these more stable patients. So it started first with just the coronary artery disease patients, but now we are extending it also to the stable heart failure patients. So we call this right siting in Singapore. So for the primary care physicians, I think it takes a little while for them to get confident with managing patients with heart conditions, with heart failure. So we started off with working with a few dedicated, interested general practitioners in the community.
Who are not afraid?
Yes, who are not afraid, and whom we can establish very close communication, so that in case patients that we send to them run into trouble, they have easy access back to us. So we have systems where we work with a few general practitioners, and once they get comfortable, once other general physicians realize it is doable, then they start we start being able to engage them and get more and more people comfortable with taking over some of the care of these heart failure patients. And as we were discussing yesterday, right, once they hit the maximal tolerated dose, patients are stable, then really they might not need to see the cardiologist anymore. And then if the general physicians are comfortable with managing them, then we are happy to discharge them. I think, a lot of cardiologists, we always feel sometimes insecure about sending our patients away and not seeing them every 3 monthly, but you're right. After a while, when this works, and then you realize that the general physicians are more than comfortable and more than capable of continuing this treatment, then we are happy to decant all of them to them. And it's also important to continually update our general physicians on the latest treatment. so that they know that they are aware, because initially it took a while for them to get used to having SGLT2 inhibitors in heart failure patients without diabetes. So we get them bouncing back and saying, hey, this patient's got no diabetes, don't worry, I've stopped the SGLT2 inhibitors. And then you realize you have to educate some of them, and then nowadays they are all very comfortable with managing. And so I think, yeah, engaging our primary care physicians to take over some of these more stable patients is an important part of managing heart failure, bringing the care to the community.
I have a question. Since you have the microphone, I will ask it to you, and then Dr. Chang will get it. How, when the patient comes with an acute heart failure, and the person clearly agrees that before discharge we should start therapy, however, there is heart failure phenotypes. Some are reduced ejection fraction, some are preserved ejection fraction, some have a mitral regurgitation, some have more right ventricular dysfunction. Then how would you, in your daily practice, how would you, in parallel, try to phenotype your patient and start the medication before discharge?
Okay, so I think...
and thank you for the question, very good. If you have other smart questions, don't hesitate. Huh?
So generally, I think heart failure or heart failure management is an art, right? Yeah. After a while, you realize
we are artists.
Yes, and we are artists. Okay, right. There is, I mean, this 4 pillars of four foundational therapy of heart failure. It applies to most of the patients with heart failure with reduced ejection fraction, and so for the most patients, whether it's poor EF from valvular heart failure or poor EF from dilated cardiomyopathy, poor EF from ischemic cardiomyopathy, they apply. So for most patients who are admitted to the hospital, we have a heart failure care path where we will remind patients or remind physicians to initiate them on this drug on the first day, on the second day. Have you done this? Have you done that? Initially, it was all paperwork, and it was a bit of a chore. Now we've moved on to electronic medical records, and these electronic systems can prompt us. We put prompts in there to remind the physicians to put in all this treatment. And on discharge, there is also a reminder, are they on these medications, to remind physicians? Because for senior doctors, you are quite used to it, but for junior doctors, we have people rotating into the departments for 6 months, 3 months, and they need... Okay. I think that's to remind me that I'm talking for too much. Yeah. So all right. So I'm going to cut it short. But generally, yes, care paths are very useful. They help us, remind us to put them on all 4 pillars. And then, of course, there are unique patients, right heart failure, some are left, valvular. Then we will... Are we supposed to run? No, right? Yeah. Okay. So then, of course, those patients you will have to individualize and then customize your treatment for these few patients. Yeah.
Yeah. A question for you, Dr. Chang. In fact, every time I have a discussion like this with Dr. Lim, there is an alarm. Then no worries. Dr. Chang, another elephant in the room, this is money. When I came to Philippines, you told me that this is, and we heard implementation, we should say bad news to have the patient taking medications. But if there is no money, there is no money. Then how do you handle this? I mean, it's probably sometimes difficult to give the right medications you prescribe, and you don't know whether the patient bought the 4 drugs, maybe they bought only 3 drugs, but they come again to ask you to help them. How do you manage this? Because this is really terrible scenarios.
Yeah, that's a realization or a reality that we have to face. No, we know what medicines to give, and unfortunately, even if you give all 4, the patients may not be able to afford. For example, if I give an ACE ARB, we do know that ARNI would be 20% better than an RAS blocker, an ACE and ARB, but unfortunately, the cost difference is really big. No? The same is true with SGLT2 inhibitor. It's a standard therapy, but the cost is still a challenge. No? It's a matter of patient education, and hopefully we will be able to do, I would say, the universal health care that the country is now pushing. Hopefully that will materialize so that the access will be better for all, no? Not only for those who can afford. No? Again, the system in the Philippines is mainly out of pocket. No? So hopefully we do have enough funds, probably with the talk by Dr. Kenneth Hartigan Go and all the policies, all the different interventions wherein we can provide financial support to all our patients. So, yeah, but that's a big challenge.
I would like to come back to Dr. Pham Minh Tuan. The cost of the medications are not the only issue. I think here in Vietnam, some of the heart failure therapies, maybe all are could be given by the hospitals, but the implementation is still difficult.
Professor, maybe some misunderstood. The cost is really a big trouble in my country. It's a big issue because in hospital maybe the charge will be covered by the insurance, but whenever the patient discharged, some kind of medication can be covered by the insurance, but
not all.
Not all. Like SGLT2 inhibitor, I think only about 70%, and for only 0%. For MRA is maybe totally 100%, and that is, it is very expensive for a patient, even for me. Well,
but don't you think that because I come back to the same example, cancer and chemotherapy, don't you think that maybe the mistakes that we all did in our countries is to not convince the politicians enough that really we have a disease here, that I think we were discussing with many of you. In Europe, we know that in some countries, only 1/5 of the heart failure patients are known. And we know maybe this figure is wrong, meaning that probably if you have 1 heart failure patients coming, probably there is 100, maybe 1,000 that are totally unknown. Then it's truly a public health issue. Do you think we should convince more our politicians?
Yes, that is what we are doing. We are trying to make a registry about HF patient in Vietnam, and we are collecting about more than 45 to 46 of the HF center who can join the USA registry graph HF. Maybe you know about that. It will run maybe 2 or 3 months later. And we hope to have the data to convince the insurance system, the policy from the government, can pay for the price of the drug that we give to the patient. That will very helpful, I think.
And what about, we talked about the 4 pillars. I spoke a lot about 4 pillars, but I think we heard earlier, and you said that nutrition,
mental health,
iron, mental health. Also, how is this reimbursed, or how do you manage all those additional benefits?
I don't think of the right time and immediate benefit for the patient, because if the patient was admitted in the acute phase, it will be you talk about the vulnerable phases. I think the kind of drugs, the acute drugs like the diuretic and some kind of the drug to give hypertension the patient, the blood pressure, good urine, then may maintain the quality of health of the patient first. And after discharge, we will discuss with during the patient was in the CCU, we will discuss with the nutrition doctor and what could be given for the patient immediately that make them better. And before discharging, we can discuss with the rehabilitation doctors and what should the patient do, even the mental health doctor, psychologist, then what should they do, what kind of exercise should they do, every day, and that can give them the decrease the in hospitalization later or CV death.
Okay, maybe a final, I think we are far, yeah. Maybe each of us, we can give a final word. Well, maybe Dr. Lim, you can start, a final sentence to give a hope to all of us, I guess.
Right, I think, yeah, for those countries, I'm very fortunate in Singapore where we do have the resources, the government puts in the resources to help support our patients with heart failure and to make the drugs available, make all this multidisciplinary care available, and to encourage all our neighbors that this is an attainable objective with time. But it takes patience. Like I said, it took 15 years for us to evolve the whole system, and once there's a will, there's definitely a way, and I think lots of communication engagement with the policymakers will help grow this system. Yeah.
Thank you very much, Dr. Cheng.
Yeah, in the management of heart failure, we wanted to meet certain objectives. One is patient and physician education. Okay. Number two, we would like to optimize the medications, which you highlighted in your presentation. I think psychosocial support will also be very, very important. And probably lastly, access to care.
Yeah.
So I think these are probably my 4 priorities in terms of how I would further improve the management of heart failure patients.
I cross fingers for Philippines. Dr. Pham Minh Tuan, what is your final hope word?
Yeah, actually, through your sharing, I know that we have many things to do for the patient with the HF management. And what we are trying to do, and in some years, I think some years later, we can have a data, because we are trying now to make a registry of HF patient, and to convince the policymaker. It is very difficult. They need the data. They don't need what you say. You need what it is. It's not important for them. They need the data, and we are trying to make the good data that can persuade them to follow us, to support us in the future.
Yeah, I think this is a very good message. Then again, thank you to Beatrice for organizing this discussion, and we wish you a very nice day. Thank you very much. Thank you. Thank you.
Thank you so much for our professor and doctors. Ladies and gentlemen, we will now have 5-minute breaks. In the meanwhile, we would like to ask our delegate to kindly take a moment to do a small survey. Thank you.
Thank you.
just wanna be alone with you. Just wanna be alone with you. Just wanna be alone with you. Same old thing, the same old thing that keeps me around. If you wanna come around, baby, it's cool. And if you wanna fuck around, baby, I do. Just wanna be alone with you. With you,
Patay.
with you, with you, just wanna be alone. What was your name again? I see so many of them come. Want me just play pretend? All your girls, they just wanna have fun. But it's the same old thing that we all see. Same old thing that keeps me keen. But I just wanna be alone with you. Just wanna be alone with you. Same old thing, the same old thing that keeps me around. If you wanna come around, baby, it's cool. And if you wanna fuck around, baby, I do. Just wanna be alone with you. With you. With you. With you. Just wanna be alone.
Ladies and gentlemen, we will continue our session shortly. Please kindly make your way back to the ballroom. Thank you. Ladies and gentlemen, we will continue our session shortly. Please kindly make your way to the ballroom. Ladies and gentlemen, our session will continue shortly. Please kindly make your way back to the grand ballroom. Ladies and gentlemen, our session will continue shortly. Please kindly make your way back to the ballroom. Ladies and gentlemen, to continue our session, I would like to invite Dr. Deborah Ignacia Abad David Una with the topic Blood Pressure Variability in Hypertension Management and Risk Assessment, a recent evidence review. Please, Doctor.
Thank you for that introduction. So I'd like to thank Beatrice for inviting me. The topic that actually they assigned to me was to talk about blood pressure variability in the management of hypertension. So these are the objectives of my talk: to define blood pressure variability and discuss the factors that affect variability, assess the role of out-of-office blood pressure, particularly 24-hour ambulatory BP monitoring, in diagnosing hypertension and blood pressure variability, and discuss the management of blood pressure variability, focusing on BP variability. So these are my disclosures. Basically, we all know that BP has a diurnal pattern. During the night, usually our blood pressure dips, so that's nocturnal dip. And then when we wake up at around 6 to 10 a.m., there's a morning surge. But during the course of the day, the blood pressure can fluctuate from minute to minute and hour to hour. So what is blood pressure variability? So blood pressure, it's a physiologic parameter characterized by continuous dynamic fluctuations occurring over a lifetime. It spans ranging from seconds to years. These fluctuations are a result of an interplay of different mechanisms in response to internal and external stimuli. So basically, it can be an interplay between environmental, seasons, altitude or stress, physical posture or volemia, and emotional factors inducing blood pressure changes. For example, last night, since Carlos Yulo, the Philippine got a gold for gymnasts, so the Philippine contingent's blood pressure went up because of emotional stress. So these mechanisms are intended to ensure an adequate organ perfusion, being able to modify your BP levels in response to the changing demands of the different organs. So BP increase when facing physical or emotional stress, and BP reduction during sleep. The size and patterns characterizing these BP variations, as I've said, it represents a dynamic and characteristic physiologic feature of the cardiovascular system. Its size varies differently among individuals in response to the daily challenges, and also determined by the characteristic reactivity of their cardiovascular control mechanisms. So what is the clinical significance of blood pressure variability? Historically, variability in BP has been dismissed as random. But based in the past few years, we've seen a lot of studies showing that increases in blood pressure variability are associated with an increased risk of cardiovascular events. So 24-hour studies show that 24-hour blood pressure variability is a predictor of cardiovascular complications and organ damage marker. So sometimes it reflects your sympathetic activation and impairment of your baroreceptor reflexes. So we see patients in the 24-hour when they sleep, there's no non-dipper status. There is an increased morning pressure rise, which shows a greater cardiovascular risk. So we'll go through the meta-analysis that actually tell us that measured blood pressure variability in clinics. So these studies actually look at variability in systolic blood pressure and all-cause mortality in clinic BP. And as you can see, actually favors a decrease in variability. What about stroke? So this is a random effects meta-analysis showing the hazard ratio for increases in blood pressure variability. And you see that it actually favors, you want a decreased BP variability because if you have an increased BP variability, then your risk for stroke increases as well. What about home blood pressure monitoring? So 4 papers reported results from 2 studies that measured midterm variability in home blood pressure monitoring. And you see that that variability in systolic blood pressure was a significant predictor of death when blood pressure was measured in the morning or in the evening or both in terms of home blood pressure monitoring. And when you use ambulatory BP monitoring as your measure of BP variability, you see that it still favors a decrease in variability. This just means that when your blood pressure is variable, then you have an increased risk of dying, as seen in your ambulatory BP monitoring studies. How about in CKD? So the clinical question in this study is asking, does variability in blood pressure either from visit to visit is clinic visit, or minute to minute predict outcomes? So they were followed up, long-term variability and short-term variability for 3 to 4 years. And the conclusion in the study is that in CKD patients, long-term but not short-term systolic BP variability is associated with the composite risk of death and cardiovascular events. How about Alzheimer's disease? So this is a post hoc analysis of a large RCT of 460 patients with mild to moderate Alzheimer's disease. And the outcome was a change in cognition after 1.5 years and a change in daily function after 1 year. So the study, post hoc analysis, concluded that high visit-to-visit BP variability is associated with accelerated cognitive decline in patients with Alzheimer's disease, and high day-to-day blood pressure variability might be associated with functional decline. So multiple studies have shown that blood pressure variability is a strong and independent risk factor for cardiovascular disease, chronic kidney disease, dementia, and stroke, as well as hypertension-related morbidity and mortality. However, the underlying mechanism is not fully understood. So it's postulated that blood pressure variability is associated with the development of target organ damage through increased large artery stiffness, vascular remodeling in the microcirculation, increase in your media to lumen ratio, decreased lumen diameter or compromised vasodilation, activation of the endothelial dysfunction, activation of the inflammatory cascade, and activation of the sympathetic nervous system, giving rise to target organ damage and a coronary event. So the thing about BP variability is how do we measure it? What are the classification and indication of blood pressure variability? It is crucial to differentiate background noise observed during blood pressure measurement from blood pressure variability. But in an effort to do so, various indices for blood pressure assessment has been proposed, including standard deviation, coefficient of variation, average real ARV or average real variability. These indices can better quantify the extreme changes in blood pressure measurements and may offer an advantage over mean values because when we check the blood pressure of our patients, they're mean values. The few studies directly comparing the prognostic value of different estimates of blood pressure variability did not provide clear indications as to which index should be preferred. So clinically, how do we classify blood pressure variability? It's classified based on the duration of your monitoring time. So it's within beat, BPV, very short term, that's beat to beat, hundreds of beats. Short term BPV, it's every 15 to 30 minutes within 24 hours. Mid-term BPV, it's day by day within 1 week. Or long term, which we do in the visit when one patient goes to the visit. Midterm would be when we ask our patients to do home blood pressure monitoring or ambulatory BP monitoring. So we go to the determinants of blood pressure variability to be able to understand where it's coming from. So very short-term BP was defined as beat-to-beat variability in blood pressure. Very short-term BP is due to an interaction between your baroreceptor reflexes, nitric oxide, your renin-angiotensin-aldosterone system, the sympathetic system, and behavioral and emotional factors. It was traditionally measured by the intraarterial method. So it's invasive intraarterial methods which have been supplanted by the PENAZ method, which uses photoplethysmography. It's based finger sensors. SD values obtained usually from spectral analysis at various frequency bands are used as a main indices for assessing very short-term blood pressure variability. Short-term blood pressure variability within a day or 24 hours, it is characterized by your circadian variability. So there's what I've said, the urinary pattern, there's a typical nocturnal dip, physiological reductions, and morning rise of your systolic and diastolic blood pressure. Currently, it can be measured by your ABPM and home BP measurement. So it's non-invasive, cuff-based measure with mesh measures for BP every 15 to 30 minutes. And the indices, as I've said, are this, SD, CoV, ARV. Basically, as a better measure of short-term variability as well as a predictor of target organ damage and cardiovascular risk. So what about the third is midterm blood pressure variability. It's between days, day to day. So it's primarily due to behavioral and environmental, like temperature, altitude, and can be influenced by the choice of antihypertensive treatment and the compliance to antihypertensive therapy. So medium-term blood pressure variability may represent a convenient data set made available by your home when you ask your patients to do home blood pressure monitoring or do an ambulatory BP monitoring. But the thing about this one is that it's susceptible to non-standardized daily measuring conditions. So it's up to your patient how they measure their blood pressure. Long-term blood pressure variability is the one that we do in our clinics. Is defined as a visit-to-visit variability in BP over months and years. Like medium-term variability, it's also primarily due to behavioral, environmental factors like temperature, altitude, and compliance to adherence to antihypertensive therapy and the choice of antihypertensive therapy. For instance, studies have noted a greater degree of blood pressure variability during the winter months compared with that in the summer, due to potentially because of the increased sympathetic activity leading to an increase in vascular resistance and sodium retention. But this is where most of the studies come from. Multiple studies have also noted a strong correlation between long-term blood pressure variability and cardiovascular events, stroke, kidney damage, and all-cause mortality. So we go to what type of measurements do we say? So these are the things that we can measure clinically. Though the standard deviation, etc., can be measured mathematically. But note that home blood pressure monitoring, out-of-office BP, and ambulatory BP monitoring, they have strong association with cardiovascular outcomes. They detect white coat and mask hypertension, except that ambulatory BP monitoring, BP is measured at work and at night, so you see a nocturnal dip of patients. The weaknesses of home BP, the patients may not correctly measure and report their BP. It requires patient training and retraining, and many of the home devices are not validated. As opposed to ambulatory BP, it's not tolerated by some patients because the BP monitor is with you 24/7. Equipment is not widely available, and it requires 2 clinic visits to set up and return the device. So we focus on ambulatory BP monitoring because it's a non-invasive technique in which a standard cuff attached to your arm is placed, and it is preset during a 24-hour period. So it actually gives you an assessment of a 24 snapshot of the 24-hour blood pressures of your patients during when they're asleep and during the time that they're doing a lot of things. So this is the category. Office BP, we know, is for the diagnosis of hypertension. It's more than or equal to 140 and or 90, depending on the guidelines that you follow. So ambulatory BP, usually it's -5. Daytime would be more than or equal to 135/85. Nighttime should be more than or equal to 120/70. And the 24 mean would be more than or equal to 130/80. If you ask your patients to do home blood pressure monitoring, the cutoffs are 135/85. So if the blood pressure is around that range, then probably your patient you need to add medications to your patients. So why am I discussing this? Because it provides a more accurate physiological description of systemic BP throughout an entire 24-hour period. And it actually weeds out the noise if that patient has white coat hypertension or mask hypertension. So basically, this is how it looks if you, basically you have to have a cuff that's really good for your patient, whether you have to have a large, an adult cuff or a child cuff. And basically, what it looks like is you have the BP and the heart rate throughout the day. So you get average daytime BP, you have average nighttime BP, you have a 24-hour average, you have a degree of variability, degree to which the BP is lowered at night, and you have an average BP, dipping pattern. So basically, these are the thresholds for hypertension, but dipping would be if the blood pressure when you're asleep falls more than 10%, then you're a dipper. And if it doesn't fall less than 10%, then you're a non-dipper. And we all know that non-dipping status is associated with cardiovascular disease. So this is a normal ABPM. So you have less than 130 BP during the times that you wake up, and when you're asleep, usually there's a more than 10% dipping status in your blood pressure, and then rises up again as you wake up. This is a typical diurnal blood pressure hypertensive patient. So you see that the blood pressure is more than 130, and then when he sleeps, it dips and then goes back again. This is a typical 24 ambulatory for a white patient with a white coat hypertension. You see that the blood pressure when you hook up the monitor is 160 and then goes down to 120 and dips when they become asleep, and then when there's a stressful meeting, like maybe when we saw that Carlos Yulo got the gold, then the blood pressure went up. I need to. And then we have a hypertensive non-dipper. So 150, the blood pressure, and then it doesn't really dip during the night. So it's less than 10% dipping and then goes up again. So why is it important? We have that concept of nocturnal hypertension, where in your nighttime blood pressure is more than or equal to 120/70. So you have the concept of reverse dipping. So reverse dipping is actually the riser. So instead of the blood pressure going down when asleep, it actually rises. So we want a patient to be a dipper. So dipping would normal pattern would be more than 10%, less than 20. An extreme dipper is more than 20%, but a non-dipper is that less than 10% from the baseline. So we all know that normally blood pressure decreases by 10 to 20% at night when we're asleep. Non-dipping and reverse dipping, why is it significant? Because there's an increased risk for organ damage and there's increased risk for cardiovascular events and mortality. So what are the factors involved in abnormal circadian rhythm? So basically, the factors that maintain our blood pressure. So activity, age, race, obesity, sodium sensitivity, lifestyle, autonomic nervous system, your baroreflex sensitivity, and aortic stiffness. As we grow older, our arteries become stiffer. So there's an abnormal nocturnal dipping in blood pressure. So much so that in the European guidelines, what was the recommendation for ABPM? It is recommended to assess nighttime BP using ABPM because it is more predictive for outcomes than daytime BP, and because nocturnal hypertension, non-dipping, and reverse dipping are associated with increased cardiovascular risk. So you want to look at the nighttime BP phenotypes, and then in isolated nocturnal hypertension, antihypertensive drugs may lower your BP and thus may be considered. In general, hypertension in the hypertensive population doesn't really matter if it's morning dosing or bedtime dosing. It actually gives you similar results or similar outcomes. So how about wearables? Because we have a lot of wearables right now. How do we make sense of it? So we have cuffless wristband, photo plethysmography, applanation tomography, pulse transit time. These sensors, they use sensors, signal processing, machine learning, and other technologies that are embedded in our wearable devices, our smartphones, our pocket devices, or other devices that are already available in the market. Except that, in the guidelines, they say that this novel cuffless BP measuring devices have a considerable potential to improve awareness, diagnosis, treatment of hypertension, except that there are several issues that need to be adequately addressed. So before these devices can be recommended for clinical use. A major concern is that there are no universal standard protocols used for validation. They're inadequate for cuffless devices, which means that their accuracy remains to be unproven. There's no agreed standard of performance for these novel technologies, and most cuffless BP devices require periodic calibration using blood pressure values. It actually you need to individualize it because you need to put in the age, sex, and other characteristics of that user. So these devices do not really measure your blood pressure, but it's used to track the BP changes compared to the calibration of BP or an attempt to predict BP using demographics and machine learning. So basically that's it. So what was the advice of the ESH? So cuffless BP devices should not be used for the evaluation or management of hypertension at this point in time in clinical practice. But we see that once it's validated, we see that these cuffless wearable BP monitors can actually give us an insight on blood pressure variability. But as of now, we cannot really recommend it. So how do we manage blood pressure variability? We know that the prognostic relevance of blood pressure variability, depending on the classification. But basically, we know that lifestyle interventions are important. So the overarching principle, as all NCDs, is to start with educating our patients with lifestyle interventions. If there are modifiable risk factors, then we need to modify them. There are only 3 things that are non-modifiable. It's sex, family history, and age. So a healthy lifestyle and positive cardiovascular health behaviors are associated with a low blood pressure variability. And of course, we have the issue of adherence. So we have to choose strategy to improve adherence. We have to choose to spend time to educate our patients and choose to simplify drug treatment so we can use long-acting medications or simple single pill combinations. And we know the importance of pharmacokinetic and pharmacodynamic features of antihypertensive drugs. So we have variabilities in pharmacokinetics and variabilities in pharmacodynamics, which can have a variability in drug disposition and in drug effects, thereby contributing to blood pressure variability. So how do we do it? So what are the implications for treatment? We need long-acting antihypertensive medications because if we give short-acting antihypertensive effects, it doesn't really straddle your morning BP surge. So you need a long-acting antihypertensive effect which persists through your morning surge, straddles 24 hours. And if you look at the overview of the most commonly used antihypertensive drugs, you see that your calcium channel blockers and your diuretics decreases your blood pressure variability. We know that in the guidelines, you can use any of the drugs, but if your patient really has blood pressure variability, then a calcium channel blocker or diuretic may be given to that patient. In this meta-analysis of antihypertensive drug effects on long-term blood pressure variability, you see in 1,372 hypertension trials, you see that blood pressure variability was effectively reduced by your calcium channel blockers. Your thiazide type diuretics also decreased blood pressure variability, whereas other drugs showed at the least effective or are at most neutral compared to placebo. I'd like to direct you to the Ascot Legacy study. It's blood pressure variability and blood pressure control in the 20-year follow-up. And it tells us that systolic blood pressure variability rather than mean systolic blood pressure was a strong predictor of cardiovascular outcomes, even in patients with normal blood pressure. So an amlodipine-based treatment compared with an atenolol-based treatment conferred long-term benefits on several cardiovascular outcomes. So what is the take-home message? So visit-to-visit systolic blood pressure variability is considered as a new paradigm for risk assessment in hypertensive patients, and future studies will determine whether this should be a new target for therapeutic interventions. So we know the long-term benefit because this is a legacy study, 20 years of amlodipine-based treatment compared with atenolol-based treatment on cardiovascular outcomes. I'd like to direct you to a concept known as time in therapeutic range. So they looked at 689 individuals from 15 veteran administration medical centers and followed them up for 10 years. So time in therapeutic range is the time that the patient has a blood pressure control within 120 and 140 and its effect on all-cause mortality. And this showed that if you have patients within the therapeutic range most of the time, then there's a reduction in mortality. This was also seen among patients with who underwent post-renal nerve denervation. So you see that when their blood pressure were consistently low within the therapeutic range for 36 months, then their risk of developing cardiovascular risk is reduced by 2 to 3%. So there's improved in time. Time in therapeutic range post-renal is associated with fewer cardiovascular events. So you want your patients to be able to bring their blood pressure down for the longest time possible. Just like your LDL, you need to bring down your LDL for life. So in summary, blood pressure variability may contribute to cardiovascular risk prevention. Standardization in methods of assessment is required to determine a universally agreed measure of blood pressure variability. So for now, clinically, as clinicians, out-of-office BP should be an integral part of hypertension care because we would want to look at dippers, non-dippers, and those with nocturnal hypertension, if available. If not, we can do home blood pressure monitoring. And we know that in all of the guidelines, the overarching principle is to use long-acting medications that can reduce blood pressure variability. And we know that if your blood pressure is reduced, then you can reduce cardiovascular events. And I think the guidelines are, because of the time in therapeutic window, we need to pay attention to the consistency of blood pressure control, the time spent under blood pressure control among treated hypertensive patients. So I guess that's the last of my slide. I'd like to thank everyone for listening.
Thank you so much, Dr. Deborah. Next, we will have a discussion together on the topic, Integrated Approaches for Managing General Anxiety Disorder and Major Depressive Disorder in Cardiovascular Patients. We would like to welcome the moderator, Dr. Melissa Paulita Mariano from the Philippines. Members will be Dr. Nguyễn Trung Nghĩa from Vietnam, Dr. Sutha Supanya from Thailand, Dr. Roberto Buenaventura from the Philippines. Please welcome doctors.
Pleasant morning. It is my privilege to be the moderator for this session. And this session will cover integrated approaches for the management of general anxiety disorder and major depressive disorder for people with cardiovascular disorders. And I'd like to ask our distinguished panelists, all of whom are psychiatrists from the Southeast Asian region, to Professor Supanya, Dr. Buenaventura, and Dr. Chung Nhi from Vietnam to kindly give a brief introduction and perhaps tell us a little bit about your clinical practice.
So good morning, everyone. Mabuhay. My name is Dr. Robert Buenaventura. I'm a consultant psychiatrist at University Hospital in Manila. I'm also a subspecialist in geriatric psychiatry and the immediate past president of the Philippine Psychiatric Association. So I also thank Beatrice for the invitation to be here with you today. Thank you.
Thank you, Dr. Buenaventura.
Yes, it's nice to see you. Good morning, ladies and gentlemen. I'm Nguyễn Trung Nghĩa. I'm a psychiatrist, and I'm a vice director of the Integrated Mental Health Care Center in the Mạch system. It's an international hospital system in Vietnam. We have 17 hospitals across the country. And our Integrated Mental Health Care Center located in an international hospital, and which is very appropriate for the theme we discussed today, because in the clinical context, I work a lot with the other apartment. I am a psychiatrist. What we give the consultant, I think that you're working at the same consultant work. So we know the context that how hard it be for a cardiologist or the other department clinician to introduce the mental health care service for their patient. Yeah, I'm hope that we will have a good discussion today. Thank you.
You're from Hanoi originally, yes?
Yes, I'm from Hanoi.
Hi, good morning. My name is Sutha. I'm a psychiatrist from Thailand, and Somdet Chao Phaya Institute of Psychiatry, the largest psychiatric hospital in Bangkok. I'm also the General Secretary of the Psychiatric Association of Thailand, and also I'm a member on the WHO CRO Mental Health advisory board. Thank you for your introduction and very happy to be here.
Thank you, Dr. Sapanya. And allow me please to introduce as well the topic for today just by giving a brief background on general anxiety disorder and major depressive disorder in cardiovascular patients. We are aware that up to 25% of patients with cardiovascular disorders may have depression and or anxiety, and this risk particularly increases among patients who have been through an acute coronary syndrome or have recently been admitted for heart failure, which really links it in line with our discussions from yesterday and also earlier this morning. We're also aware that depression and anxiety can significantly increase the risk for morbidity and mortality for these patients. And because this finding has been present for more than 50 years already, we're very well aware about the need to screen and to manage these disorders in cardiovascular patients. And I perhaps just wanted to sneak in this note a little bit in case anyone of the audience might have questions for our psychiatrists. They are more than happy to answer these questions. Now, perhaps just to get the ball rolling, I wanted to ask our panelists how often you actually see patients with depression or anxiety with comorbid cardiovascular disorders in your practice. Dr. Sapanya?
I mean, we see them all the time, like you were saying. It's bidirectional. Most of people with depression and anxiety are more likely to develop cardiovascular diseases and vice versa. So we see them all the time. So I wouldn't say it's how often, but it is already within the practice that we always see them. And that's my take.
So for me, it's about 20%. With 10% within that was the patient who referred from the cardiology department to our psychiatry department. And the other 10% is our own patient. But after we assess, we see that we do the screening test and so on, cardiology tests, and we figure out that the patient, apart from the anxiety, depression, they also have the comorbidity of the cardiology issues.
The numbers that we see in the literature are technically underreported. So although the estimates can be between 25 to 30%, we do think that it's much higher than that. There are several reasons for that. One common reason is that, for example, in the Philippines, there's still a huge stigma about being referred to a psychiatrist. Imagine you're a patient who suffered an acute myocardial infarct and your cardiologist wants you to be seen by a psychiatrist. So there's a high, leakage. So a lot of these individuals who are being referred by their internists or cardiologists to a psychiatrist actually do not go unless they are in a in-hospital setting. In an outpatient setting, there's a higher likelihood that they may not go to their psychiatrist. So we believe that the values that we get in the literature are really underreported.
I think we have very similar findings, very similar experiences with this. And part of that experience is stigma. Sometimes there's stigma from the patients themselves. They think, oh, but I don't want to be referred to a psychiatrist. I'm not crazy. And all I'm having are palpitations or a lot of stress. And so the burden or the shared responsibility will fall on the cardiologists and on our primary care physicians. How could we make it easier for them to screen for GAD and MDD in their clinical practice? Maybe from this way?
Okay. Screening is actually very easy. If you look in terms of the basic screening tools that the World Health Organization together with Pfizer developed, so I'm referring specifically to PHQ-9 and GAD-7. PHQ-9 screens for depression, GAD-7 screens for anxiety. So this can be self-administered. So the patient, while waiting in your clinic, can actually do them. And then the cutoff score is roughly about 15 points. And then this can give you a better idea about the presence or absence of depression and anxiety. So this is one way by which we can deal with it. What I do, because I've worked with the Philippine College of Physicians about particularly this issue, in terms of being able to motivate patients with mental health conditions to go see a psychiatrist. What we emphasize to the internists or the non-psychiatric physicians is to leverage the doctor-patient relationship. Patients generally have a huge trust on their primary care physician. And the primary care physician may have to explore as well whether the patient will be willing to be seen by a psychiatrist. If there's a willingness, that's great. If there is hesitancy, let's say due to stigma, then we encourage the primary care physician to manage the patient with GAD or MDD in collaboration or in consultation with a psychiatrist. So in that way, the patient with GAD, or general anxiety disorder and major depressive disorder, can be taken care of, even at the setting of a primary care physician level. Thank you.
Okay, so from my experience, we also use GAD-7 and BHQ-9 for the screening because it's very convenient and also high validated and easier to standardize in the new language. 1 year before and before that, we use it and we get the nurse to have the patient to do that screening test. But in this very new year, we employ the AI machine learning chatbot, and they can talk to the patient as they will, and they can ask questions and also analyze the result of BHQ-9 and GAD-7. The survey the patient have told us by the survey that they love to do in that kind of way because it's kind of interesting, more interesting and more fun when you talk to a chatbot, and it's also feel more secure to protect their information and identities. And after that, the chatbot also can give the suggestion for the patient. What is the next step? Can I send the result to your cardiologist, or can I refer you to the psychiatrist who I know very well? And the chatbot also explain about what is MDD, what is generalized anxiety disorder, and how it impacts the cardiology issues of the patient, to have them to know well more about the impact and relation between and the need to get mental health caring. So I think it's a kind of experience that can have the way of referral be easier. And another ideas I want to impose is that to destigmatize the mental health or crazy suppose definition in the community is, I think, is a global issue. When I visit Taiwan, I visit Malaysia, Philippines, and also Thailand, we psychiatrists share the same issues, the same problem we face. So in Vietnam now, we have a national program which encourage the psychiatrists and also psychologists to create the social media content. We share the tip, we share the way to create a very short video and we tell the story we have faced in the clinician context. What is the reason for that? We know that all the patients do not feel, all the common people do not feel impressed when they heard the number or the data. But rather than that, they feel impressed about the story. They can figure out what is the similar thing in my story and someone else's story, and feel no more lonely. I'm not the idiot, I'm not the weird, I'm not the odd of the community. And they are understand by the story that someone else suffer the same as me. And MDD or GAD or even psychotic symptoms disorder is a common issue, and I have the right to have the situation, and I also have the right to be care of and to treat that kind of situation. So that's the way we are doing to stigmatize the mental health issues in our country.
It's fantastic. I hope we can do similarly in ours.
That's
Dr.
really
Supanya.
interesting. You see, in Thailand, so we embedded the screening of depression already into primary care using easier questionnaires in Thai and having quite simple clinical practice guidelines for GPs. And then there's a referral pathway for them so that they can start treating patients that they think that they can first, and after which then they can be referring their patients to a more specialized system. Not so much on the anxieties yet. Stigma in Thailand, I think, is getting better during the past few years. More people are coming to the hospitals than before. But there's culture-based biases in Thailand, at least, when people don't actually know how to express their emotions. So anxieties, depressions are not easily explained to the doctors. Usually they come with pains and things like that. So it's going to take a while, but I agree with your approach using easy questionnaires that they can do for basic screening and then being sent for treatment.
But I have heard that Thailand is a country of smile. Everyone happy.
Everyone smile, but not everyone is happy.
Perhaps a little bit of masking, and this is something we do see in our culture as Asians as well. Thank you for that. I think what we pick up from that is that screening is essential. And even in the Western countries, the American Academy of Family Physicians recommends that all patients, regardless of whether or not they have a cardiovascular disorder, be screened at least once yearly for both depression and anxiety. And the tools that we have available for us are the PHQ-9 and the JD7, very, very simple to administer. Dr. Buenaventura emphasized the importance of rapport in being able to screen for these disorders among your patients. Dr. Chung Nhi emphasized integrating AI and the use of narrative stories to get the patients on board. And Dr. Supanya, at least in Thailand, they've been able to integrate already screening for depression in primary care. I think that's wonderful. And we don't just screen, of course, to get the numbers. We screen so that we can effectively manage our patients well. And so I wanted to pose a question to you. How do you feel like our cardiologists, our family physicians, how can they effectively manage patients who they pick up with major depressive disorder and GAD? What are first-line evidence-based management approaches for these that they can do in their clinic? Maybe a toss-up for anybody.
Okay, so I just go, then we can reverse. I mean, like Dr. Moreno said, I think the past 2 days I've heard a lot on, your specialty talking about stress. Actually, quite heartening because it seems like everyone recognizes that there's stress in your and our patients, essentially, not just on the biological side, but the psychological side. So it's not just physical health that is important, but also mental health. And I've heard that a lot the last 2 days. So I think at least most of you recognize, and the evidence base for now is that not only medicine is going to be effective. Only about half or less are going to respond to the medicines that we use or every antidepressants that we have at the moment. But psychological interventions, exercises like you stress, are going to help mental health a lot. how then can we emphasize this holistic care into treating our patient using, basic medicines, monitoring, and also helping them to understand what is going on. The chronicity of the diseases, the heart failure is big shock to anyone, not just the patient, but ourselves, if we have them, for example. That's my first take on your question.
And Dr. Supañas emphasized lifestyle modification, psychoeducation, psychosocial strategies, which do go a long way in managing major depressive disorder and general anxiety disorder. And perhaps for our other two panelists, what about medications? When can we start medications for patients with MDD and GAD? And also tackling this on, given that they already have comorbid disorders, they already have other medications, what are certain safety concerns we should be watching out for?
I think in this panel, I'm the most senior, shall I say. I've been in practice for more than 35 years. So I've come into a time in clinical practice in psychiatry that we used a lot of tricyclic antidepressants. Okay. So this was a point of concern for using these types of medications in patients with cardiovascular disease because of the very significant drug-drug interactions. So fortunately, the selective serotonin reuptake inhibitors came about, and this was such a big relief. One of the Dr. Mariano and I were talking about this yesterday. One of the landmark studies, I'm sure the cardiologists are familiar with this as well, was the SAD heart study. As you know, this came out in early 2000s. This was sertraline in the use of sertraline in depressed patients with cardiovascular conditions. Okay. But this was not an efficacy study. This was more of a safety study. So they compared a group of patients with cardiovascular conditions with depression who were treated with sertraline, a selective serotonin reuptake inhibitor, versus a group that was treated with placebo. So they saw that there was no difference at all as far as safety concerns were, as far as safety was concerned. And so therefore this reinforced the use of antidepressants, the newer generation antidepressants in patients with cardiovascular conditions and concomitant mental health conditions. So this was studied in 3 groups of patients, those with acute MI, unstable angina, and then a corollary study was in patients with heart failure. Okay. So that was it. Then recently, about 3 months ago, an article was published in the Journal of the American Heart Association. But this was a retrospective study using Medicaid data in the US. They looked in terms of the value of using treatments for patients with depression and anxiety in individuals with cardiovascular conditions. And they saw that the use of, because my colleagues were already referring to not just antidepressant treatment, but also in psychological treatment, such as psychotherapy, specifically cognitive behavioral therapy. So they saw that the combination of both psychopharmacology and psychotherapy in patients with depression and concomitant cardiovascular conditions proved to be a much better option for patients with depression and anxiety, rather than not giving them any psychiatric treatment at all. So this had an impact as far as their admissions, ER consultations, and other outcomes. Okay, so patients who had cardiovascular diseases and concomitant anxiety and depression treated with both psychotherapy and psychopharmacology did better overall in a 24-week observational period. So we continue, and that's why these studies like this continue to support what we do in clinical practice. So, and hopefully would also reinforce to our patients that despite the stigma, that there will be better outcomes for them if they have additional treatments for their other conditions.
Perfect. And what we pick up here is certainly SSRIs remain first line for the management of both general anxiety disorder and major depressive disorder, even among patients with cardiovascular diseases. They are safe and efficacious, but we find the most beneficial outcomes when we combine this with psychotherapy. And Dr. Chung-Yi, you have the privilege of answering the question from the audience. And the question goes, how do you manage a patient with JD or MDD with comorbid illness anxiety disorder or somatic symptom disorder, preoccupied with having cardiovascular symptoms or cardiovascular disease? Moving a little bit now beyond GAD and into somatic symptom and illness anxiety disorder, how would the management strategy be like?
Long answer in short, please refer to psychiatrist. Yeah, we're talking about how to manage MDD, GID in patient, and we, as psychiatrists, we really encourage our colleagues as cardiologists or primary care doctor to manage them, the patient, the more, especially when the level of depression or anxieties is only from moderate to average moderate. They can start with SSRI medication like sertraline themselves and manage themselves because as Professor have said, and even in evidence we see that it's very safe. It's safe to use the medication for the patient. But in the complicated case like that, especially for somatic symptoms and also illness anxiety disorder, the two type of thing is have very rare evidence of the SSRI or any kind of antidepressant or anxiolytic medication to so effective on them. Especially for somatic symptom, when someone express a lot of somatic symptoms like the pain feeling and also some kind of distress in their body without any medical explanation. So we as psychiatrists and also psychologists, we understand that there must be something underlying the unconscious or something related to the trauma from the childhood or even in the life. So it needs to be thoroughly and deeply intervened in terms of psychological treatment. Yes, so only for the somatic symptoms and illness, this anxiety disorder belong alongside with the medication. We need the mental health care professional to assess the issues in terms of psychology.
I mean, that is really tough question, and he answered it very well. I think you're too handsome for some people, so they ask you this really tough question.
Thank you for whoever it is that asked the question here, and we maybe have time for one more question just in case there's someone who would like to ask any. This does bring us to the question of when do we, other than in this very particular case of a comorbid illness, anxiety, and somatic symptom disorder, when else perhaps should primary care physicians or cardiologists actually refer to psychiatry?
I'll just dovetail from what Dr. Supanya mentioned earlier. A lot of the depressions and anxieties actually will remit, okay, over a short period of time. So you can just wait and observe. Okay. What our recommendations for referral to psychiatry would be, number one, if it's a complicated condition. Like you said, aside from anxiety and depression, the patient suffers from other mental health conditions such as substance abuse or a personality disorder, because that can complicate the treatment. So that will be a good point for referral. Number two, if you've already tried an antidepressant or an anxiolytic for an optimum period of time at an optimum dose. So this would mean between 6 to 8 weeks, okay? And the symptoms are not remitting or the symptoms are not improving. So consider the possibility of referring the patient to a psychiatrist. Number 3, if it becomes too distracting or too difficult as far as your practice is concerned. Because, if, for example, if it's taking you a long time to be able to interact with the patient during their consultations because they keep bringing up new problems or additional problems, then consider the possibility that this patient may actually benefit from a psychotherapeutic maneuver with a psychiatrist. So, but there are other indications, but I think in clinical practice, these are the most common ones that we see.
And I add a little bit to what Dr. Bonaventura said. In settings that have multidisciplinary teams, especially liaison psychiatry, consultation psychiatry, in people who refuse treatment, especially, they don't want to see psychiatrists, referring them for a consult for a psychiatrist and their team to just visit is also going to be useful. But that limit to settings that have these services available, just to add a little bit on.
And it seems that the answers coming from our panelists have encouraged another member of the audience to ask a question and or give a comment, perhaps.
Kenneth Hartigan from the Philippines. Quick comment. Thank you for your talk and this panel. I have a few questions that is sort of an out-of-the-box thinking.
I'm sorry, please don't ring the bell on us, okay? Our blood pressure variability.
Yeah, cause anxiety, no? Yeah. Okay, there's so few of you psychiatrists in the region. And what do you think would an epidemic of mental health condition look like? Let's just say COVID as an example. Did the national health financing even cover for services and products? What must change in order to accommodate this practice? Even, for instance, cardiology training. Should the cardiology fellowship training accommodate this new way of thinking? What are your thoughts? Thank you.
Fantastic question. And I think perhaps with COVID, each country managed differently. And perhaps if we were, I hope not, to have a mental health epidemic, which we kind of did see after the COVID, then maybe each country would have their own perspectives. And perhaps we can start with Dr. Bonaventura, if all right.
Yes. Excellent question, because I wanted to point out that one of the, heaven forbid, advantages of the COVID pandemic was that it, because it led to an increase in the diagnosis of anxiety and depression, particularly in primary care practice. And the psychiatrists became so busy during this period of time because our caseloads increased dramatically. Okay. But this led to changes. I'm not sure with cardiology, but I'm talking with the Philippine College of Physicians. So these are the basic internist group. They collaborated with the Philippine Psychiatric Association in terms of being able to help identify and at least manage in a short term individuals with anxiety and depression. And at the same time, be able to self-monitor, to monitor themselves, because the increase in anxiety and depression did not just happen among patients. It also happened among physicians, particularly the frontliners. So in our setting at a university hospital that we were working with, we were actually dealing with the frontliners also. But a lot of them were consulting with us on a secret basis because they didn't want to be seen going to the office of the psychiatrist. So yes, what happened was the Philippine College of Physicians developed, integrated in their training program to develop training physicians to be able to help identify and manage on a short-term basis patients with anxiety and depression. Another outcome of that was that the Philippine government also came up with outpatient benefits package for mental health because of the increase in the prevalence of the condition.
Yeah. I really love the questions from policymaker. From national-wide view and also globalized view, I see that the pandemic, the mental health pandemic is happening. It's actually happening. When there's social media and the platform social media is have been and emerged these days, the mental health issues is not a transmitted and also infectious disease, so we cannot see it or know it or locate it so clearly at COVID-19. But it actually happened. For example, do you know that the trend in psychiatry recently is about ADHD, attention deficit and hyperactivity disorder is increased in number when in the number we identify. And how hard is that? The ADHD prevalent within the community is 10%. It's also a very small number. But if you compare it with a disease everyone know, an illness everyone know is diabetes. You know, how you can guess about the number of diabetes prevalent within the community? It's only 8%. But how about 10% of ADHD when we do not know that? And 8 to 10% of depression within the community and we do not recognize it. In my point of view, the pandemic is happening. The question is that the question is not when did it happen, the question is how we can locate it, how we can identify and how we can help each other within the community. Yes, so it's my answer. Thank you.
I mean, just to add to that a little bit, and I recognize that your question is quite important. What I find, at least in Thailand, interesting is that the number of patients did not decrease at all during COVID, and even more after the COVID. So psychologically, the anxiety about the disease, the post-pandemic world, even now with the disruption of technologies, laying off, the economic crisis here and there, are causing a lot of anxiety and depression in the population. So how we tackle them with so low resources, like you said. At least in Thailand, we are trying to train more psychiatrists, and healthcare in Thailand is covered by the government most under universal coverage scheme, which in itself is not perfect, but then it enabled most of the population to have access to treatment. But we still have very few psychiatrists in Thailand, less than 1,000 for almost 70 million people. And I'm part of the training committee that we will have to try to at least somehow train more people. But it's not going to only be on psychiatrists, but it's going to be on everyone. Even I always go back to the law college to get this through to the medical council who oversee training of doctors in Thailand, that medical student has to recognize the importance of mental health. We taught all this, the holistic care and everything, but once we graduate, somehow it is lost somewhere, and it become specialties and subspecialties. You look at heart, and that's not everyone else. Me as well. I don't know a lot of things you discussed yesterday and today on heart failure and things, because it's not my specialty anymore. But how to make that still embedded in our students and doctors and all medical practitioners in the long term is going to be really helpful. Like the first question that Dr. Mariano was asking, we screen for our patients for the hypertension and things, and they every visit, and then we told them, okay, you probably need to see an internist now, or things like that. How do we combine all this so that resources are enough for everyone? That's my take.
fantastic. And I must apologize, we might not have time for your last words as I see people, you know, I'm a psychiatrist, I can see the faces of people. It's like, oh my God, what time is it? But I think this wraps up our session really nicely with that question from Professor Hartigan-Go and the answers that we've got. And what we feel, I think, in general, is that mental health invisible epidemic is upon us. And it started very slowly, even before the COVID pandemic. But post-pandemic, mental health disorders, the prevalence have shot up significantly, especially in the younger individuals. And this is why we're having this session today, because we, as psychiatrists, cannot act alone, and we do need your help in emphasizing an integrated approach in the management of major depressive disorder, general anxiety disorder, in screening for other disorders among your patients. And I'd like to thank again our panelists very much. Thank you, Professor Hartigan-Go, and to the other person who asked the question. We want to paraphrase what Dr. Go said yesterday, that we all have a duty of care, a shared responsibility, and this applies also to mental health. Thank you very much. Thank you.
Thank you, our doctors. Before continue with the discussion session, now we will move to the case presentation. Our chairman will be Professor Peter Lansberg from the Netherlands, Professor Abhijat Sukongtasan from Thailand.
All right, everybody, I think that we should start now. And I have one good news for everybody. I hope that you still got some energy left for our last session. All right, the good news is that we will finish at 12:30 sharp, according to the time. Is that the good news or is that bad? Good news, right? We finished on time, 12:20. Okay, Mr. Statement, all right, it's good. So the bad news is we have 3 cases presentation. And probably the presenter may have atrial fibrillation because a lot of stress, all right? Because we have maybe only 10 minutes for presentation and maybe just a few minutes for the question. So without delay, I will introduce you to the first presenters, Dr. Francis Martin N. Armada, Chairman Section of Cardiology, Medical City, South Luzon. He's from the Laguna, Philippines. He's going to present us the case about primary prevention in an elderly with high blood pressure. So please continue.
Okay. Good day, everyone. I'm so grateful to be invited here by Beatrice in this beautiful city of Da Nang. I'm also equally thrilled with enthusiasm learning from the experts among us. At the same time, I'm having a generalized anxiety disorder with my presentation. Having Professor Landsberg, Professor Pidra, and Professor Mabasa here, and Dr. Go. Okay. We physicians prove to be good listeners and the masters of empathy, especially in dealing with our elderly patients. We have to adjust on their moods and their cognitive function. These patients are more likely to follow their treatment plan and practice self-care when they feel heard and understood. I am tasked to give a presentation in elderly with hypertension. So, the United Nations and the researchers use the definition of older persons as those 65 years older or more. In the Philippines, the terms older people, elderly, and senior citizen are used synonymously to define the population group of 60 and over. The World Population Prospects 2019 predicts that by 2050, older people will make up about 16.5% of the total population. In 2025, it is expected that 10.25% of the Filipino population will be elderly. So this is a case of a 69-year-old male who came into the clinic due to elevated blood pressure. This was associated with headache, dizziness, and neck pain. His usual BP range 130 to 120 and diastolic blood pressure of 90 to 70 millimeter mercury. Blood pressure at the clinic was 155 over 80 millimeter and a heart rate of 80s to 90s and regular. So patient was diagnosed to have impaired fasting glucose 2 years ago, but no medication was given. His total cholesterol and LDL were intermittently at the top normal and elevated levels, but was given a statin based on the results. He was diagnosed to have benign prostatic hyperplasia and had cataract surgery. He's a businessman, plays golf 1 to 2 times a month. He occasionally smokes cigarettes and drinks alcohol. His father had stroke, and most of his siblings have hypertension. So medications, he was on atorvastatin, tamsulosin, and multivitamins. So the laboratories, FBS 106, glycosylated hemoglobin of 7, total cholesterol of 203, LDL of 103, and triglycerides of 156, and the creatinine was normal. So the first question is, what blood pressure category does the patient belong? A, normal. B, elevated blood pressure. C, stage 1 hypertension. D, stage 2 hypertension. So you can do the polling now. So just take a picture of the QR code and put your answer. Okay, everybody got 60, normal, 17. Okay, everybody got stage 1, letter C. The next is elevated blood pressure. So, well, the answer is stage 2 hypertension, okay? This is the AHA blood pressure category table. Our patient's blood pressure is 155 over 80 millimeters under the category of stage 2 hypertension based on the ACC AHA guideline. So this slide showed the recent guideline difference between the 2017 AHA and the 2023 European Society of Hypertension blood pressure categories, okay? So both guidelines stress the importance of standardized, accurate measurement of blood pressure and recommend the office-based measurements for diagnosis. However, the 2023 ESH guideline emphasize using the out-of-office BP monitoring, could be your home-based and ambulatory BP monitoring, in addition to the in-office measurements to diagnose hypertension. So the ESH recommends a threshold of more than 140/90 millimeter mercury, grade 1, for the diagnosis of hypertension, whereas the AAC guideline recommends a lower threshold of more than 130/80. systolic blood pressure ranging between 130 and 139 or diastolic blood pressure ranging 80 to 89 represents stage 1 hypertension in the ACC AHA guideline, whereas the ESH guidelines classify these ranges as normal or high normal, basing from the table. No? Whereas the ACC AHA guidelines categorize BP of more than 140/90 as stage 2 hypertension. The ESH guidelines subdivided the BP levels to more than 140 into grades 1, 2, and 3 hypertension. Now, next question is, how do we treat the patient? A, you do advise lifestyle modification. You set up the blood pressure goal and you start BP lowering agents, or all of the above. So here. Okay, scan the QR code. So the answer is unanimously all of the above. So lifestyle modifications, no? The DASH diet has been approved, no? It emphasizes consuming fruits, vegetables, whole grains, lean proteins, and low-fat dairy products with limiting the sodium and saturated fats. This diet has been shown to lower the blood pressure. Sodium reduction, limiting sodium intake to less than 2,000 milligrams per day, and even lower for certain individuals with specific health condition, can lower the blood pressure. This involves reducing the consumption of canned foods, canned soups, fast foods, and adding less salt to meals. Weight loss, achieving a healthy weight through combination of balanced diet and regular physical activity can significantly reduce blood pressure. Also, we can recommend physical activity. Engage in moderate intensity aerobic exercise such as brisk walking, swimming, cycling for at least 150 minutes per week. Strength training exercises should also be incorporated. Another one is smoking. It is detrimental to the vasculature, increase the risk for vascular disease. And alcohol moderation, limiting intake, as we've been taught, to moderate levels, 1 drink per day for women, and up to 2 drinks per day for men is recommended. Regular physical activities, 90 to 150 minutes per week, would have an approximate impact of 5 to 8 millimeter decrease in systolic blood pressure. Thus, we should reinforce this to our patient, no matter what. No? Now, stress management has been discussed in the previous lecture. No? Chronic stress can contribute to elevated blood pressure. Techniques such as meditation, yoga, tai chi can help manage and lower blood pressure. Adequate sleep is crucial for maintaining overall health, blood pressure regulation. So establishing a regular sleep schedule and adopting good sleep hygiene practices can contribute to blood pressure control. Maintaining strong social connections and having a support system can help reduce stress levels, improve the patient's overall well-being. So what are the considerations for drug selections? A, patient's comorbidities and their respective medications. B, patient's preference and cost. C, adverse effects. D, all of the above. E, all except B. Okay. So everything got it, no? So all of the above. So majority chose all of the above. So what it is? So comorbidities, the presence of specific comorbidities such as chronic kidney disease, diabetes, heart failure, may influence the choice of antihypertensive medication. Some medications have beneficial effects in certain conditions, making them preferable choices. Cognitive decline and autonomic dysfunction are the dreaded end results of hypertension. So, elderly individuals often have multiple comorbidities and medications, increasing the risk of drug interactions. Health professionals should assess the potential interactions between these patients' medication. Factors such as amount, dosing frequency, and ease of administration should be taken into account to ensure adherence and optimize the treatment outcomes. And elderly individuals may become more susceptible to adverse effects of medications such as hypotension, electrolyte imbalances, and dizziness. So the ACC guidelines recommends treatment to BP target of less than 130/80 for many patients. That's the target goal. The ESH guidelines recommend BP treatment targets differ from the basis of the basis of age. Although the ESH guidelines recommend the same BP treatment as with the AHA guideline, the ESH guidelines recommend higher BP treatment thresholds for adults more than 65 years of age. So patients in this age group with isolated systolic hypertension for adults more than 80, the threshold is more lenient, targeting between more than 40 to 150 millimeter mercury. So both AHA and ESC guidelines recommend the same BP treatment for patients with hypertension and coexisting CAD, DM, diabetes mellitus, and cerebrovascular disease. So what's the difference between the two and how it came about with the different treatment goals? The SPRINT trial enrolled patients with pre-existing hypertension. This is for the ACC, where the ACC guidance guide came from, the SPRINT guidelines. Also, they enrolled more than at least patients with pre-existing hypertension with a baseline of 139 millimeter mercury on a mean of 1.8 antihypertensive patients and a very high Framingham ASCVD risk score of 25%. Another thing is the SPRINT trial used an unattended automated BP measurements, which somewhat inconsistently underestimates the office systolic BP by 15 millimeter mercury. So the HOPE trial gave the ESC and ESH pause in terms of lowering the diagnostic and treatment thresholds, recruiting largely normotensive, albeit compared with the SPRINT in population, with intermediate ASCVD risk, and using the more conventional BP measurement rather than the automated BP monitoring. HOPE-3 trial showed no reduction in CV events with further BP lowering. Treating those with systolic BP of 120 to 130 millimeter mercury seems to be marginal at best and limited to those with very, very high risk. So both guidelines recommend that the initial therapies include at least 4 major classes, your ACE, your ARBs, the thiazide, and the calcium channel blockers. The ESH guidelines continue to include beta blockers as an optional first-line therapy on the basis of the RCT evidence. The guidelines both emphasize use of beta blockers for patients with history of ischemic heart disease or heart failure. The ESC guidelines recommend consideration of beta blockers also in the treatment of atrial fibrillation, hypertension, pregnancy, and hyperthyroidism. So both recommend single pill combination. So the ESC guidelines recommend the preferred combination of ACE, ARBs with either calcium channel blockers or thiazide like diuretics. Whereas the ESH guidelines strongly emphasize initial treatment with 2-drug combination for most patients with hypertension. The AC guidelines recommend this approach for patients with stage 2 hypertension. Okay. So our treatment plan for this patient is to give calcium channel blocker or ACE or combination if target blood pressure is not achieved in 3 months. So we can give also statin or ezetimibe or a PSK9 or a small molecule RNA and employ lifestyle modification like smoking cessation and exercise. So what are the take-home messages? Observational studies in very older individuals treated for hypertension have shown higher morbidity and mortality rates compared to those with lower blood pressure levels. Clearly, in very old patients, the therapeutic strategy of one size fits all cannot be applied. because of the enormous functional heterogeneity of these individuals. So we propose taking into action the function, frailty, and the autonomic status of the older people. There is growing evidence that the outcomes of the health care for seniors are dependent not only on patients' physical health status and the administration of care for their biochemical needs, but also upon the care for patients' needs for psychosocial, economic, cultural, and psychological vulnerabilities. Lastly, older patients who are socially isolated, emotionally vulnerable, and economically disadvantaged are particularly in need of support that we physicians could provide. So that's all. Thank you.
I think we don't have a lot of time for questions because our schedule is sharp 12:30. So I would like to invite Dr. Emily Tan Lay Koon from Malaysia to discuss another important patient, more prevalent, I think, in Southeast Asia than in Europe or US, a patient with a history of stroke, right?
Thank you, Prof. Lesberg. I think you don't have to worry about time because I'm feeling a lot of palpitation. I probably speak very fast after drinking the Vietnamese coffee. You know, it's really strong. I never drink coffee. I'm really having a lot of palpitation. I'm not kidding. So anyway, it's my great pleasure to be here in this beautiful city of Da Nang. And I'd like to thank the organizing committee for inviting me. And it's my great pleasure to present to you my patient who is 83 years old. So Malaysia is a land of the elderly. Yeah? So for me, definition for Malaysians probably more than 80 years old considered elderly because we have a 97-year-old Prime Minister previously. So a lot of my patients in my clinic are actually octogenarians and nonagenarians. So my patient is actually 83 years old, has long-standing hypertension. And, you know, thanks to Dr. Google, he actually Googled and he thought that when, you know, I'm 83 and with my kind of blood pressure, 140, 150, I'm fine, you know. So he decided that he didn't need any medication and he defaulted all his follow-up. And he was actually quite well and he's able to drive around, you know, attending to his business. So he's got no problems at all until 1 month ago. I just had this patient recently, actually, when he actually flew in from East Malaysia to Kuala Lumpur, and he was at the KL International Airport to meet his daughter, who was flying in from Australia. So happily, they were at the cafe, you know, meeting up, chit-chatting, and suddenly he realized that one of his bag was missing. So he went frantically around to search for his bag. So unfortunately, I think because of his high blood pressure and everything, he actually collapsed. Yeah, he had the cardiac arrest. But thankfully, his daughter was trained in CPR, administered CPR immediately, and even used an AED, which delivered at least 2 shocks, you know, it was 2 shockable rhythm. And after 8 cycles, before the arrival of the emergency medical team, he actually had resolution of his spontaneous return of his circulation. So it's very good CPR. So this emphasizes the fact that I think we should train our general public in CPR. It's very important and very life-saving. So in Malaysia, we do have programs to get, you know, lay people involved to learn CPR as well. So he was ventilated when he reached the hospital, and the CT brain, among other things which was done, showed 2 things. Yeah, there's a chronic infarction, as you can see over here in the lacuna, and also something fresh. Yeah, this is a thalamic bleed on the left side. So this was his ECG. Yeah, when they ventilated and intubated him, his blood pressure wasn't very high at the time, probably because of all the, you know, anesthetic drug, and it was just about 149/90. His pulse rate was just 62. His D-dimer, because we're thinking whether it's a pulmonary embolism or not, D-dimer is normal. His troponin I actually was 129, but over the subsequent days, it actually went up to 1,400. But there was no ST elevation on the ECG. So he was actually quite well, a remarkable recovery, extubated over the next 3 days. He was a little bit confused because of his thalamic bleed, but remained stable. And 10 days later, he was referred to my cardiac center for further investigation and evaluation and management. So his BP, when he arrived to us, was not too bad on treatment. Troponin T has come down to 77. His renal function was normal. His lipid profile wasn't too bad, actually. LDL-C of 2.3, which is equivalent to 88 milligrams per deciliter. TG normal. His glucose was just mildly elevated, but I think most of us would take this as probably acceptable for an 83-year-old. So because of his thalamic bleed, we didn't actually do the angiogram immediately. We actually waited until he became rational, just about 4 or 5 days later, and that the neurologist actually cleared him and said that we can actually go ahead and do a coronary angiogram. So his coronary angiogram actually shows triple vessel disease. Yeah, this is the left coronary system. This is the left anterior descending artery. You can see the stenosis diffuse all the way to almost distal. And this is the left circumflex artery. You can see also diffuse disease. And there's a totally occluded right coronary artery with TIMI 1 flow distally and a retrograde from the left side to the distal part of the RCA. So, ladies and gentlemen, how do you think you would manage this patient at this juncture? Would you just continue medical therapy for him, or medical therapy plus coronary angioplasty, or coronary intervention with implantation of stent in all 3 vessels? Or would you go for CABG, or would you go for medical therapy plus revascularization, either with PCI, CABG, and also implantation of an, a defibrillator, yeah, AICD. What do you think? I think you can start voting now with the Slido. I just want to see how, the audience are from different countries. So if you encounter this patient in your clinical setting, what would you do? Is there some problem? Do I need to advance the slide? Huh? Sorry, I think there's a problem with showing you the poll result, but I gathered that there's almost equal distribution for all the 4 categories, right? Yep, okay. Okay, interesting. So only about 14% would actually go for all 3, yeah, including the implantation of a automated implantable cardioverter defibrillator, yeah, AICD, in case you were wondering what it was. So most of you will actually go for angioplasty. I think in terms of revascularization, I think it's a matter of your clinical judgment. I think either PCI or going for CABG, both methods are, I think, equally acceptable. But the question is whether you actually would implant an AICD in this patient. So because I was told that this talk was only 10 minutes, so I didn't have time, I didn't prepare any slide to show you, but certainly I think in our opinion, this patient needs an AICD because this is secondary prevention. Yeah? Because he had, shockable rhythm when they put an AED. I think he actually had pulseless VT or he had ventricular fibrillation. So I think this is secondary prevention. So we decided that actually he needed an AICD, and we sent him for CABG because it's got quite bad triple vessel disease. And of course, I think it's not wrong to go for PCI because in an 83-year-old, so I think both methods of revascularization is acceptable depending on the patient's preferences, and other things in your clinical setting. And we actually put this patient on dual antiplatelet agent, and the antihypertensive would be amlodipine 10, perindopril 4, and bisoprolol 1.25. And we gave him a high-intensity atorvastatin 40 milligrams daily. And with this medication, we actually managed to achieve his blood pressure to be about 120 to 130 over 70 to 80 millimeters mercury. So I think the next question is, this is quite difficult clinical situation when you have both a acute coronary syndrome and a stroke. So what do you think is the incidence of this, what is the prevalence of this happening like both together? So what do the audience think? Is it like less than 0.5% of the time, or is it
0.5 to 1%? Was it about 1 to 5% or more than 5%? I think there's something wrong with the thing because A is all the way down here. Okay, maybe I'll show my slide. So this is a very difficult situation clinically. And so when you either had acute coronary syndrome or a cerebral vascular accident, actually there's increased risk of the other, yeah, and vice versa. So the prevalence is actually between 0.7 to 0.8%. Yeah, when a patient has acute coronary syndrome, they actually can have also cerebral vascular accident or a stroke. Okay. So vice versa, about 70% of those with stroke, right, actually had elevated cardiac enzyme, but not a myocardial infarction. And the mechanism of this is thought to be due to sympathetic nervous system activation, and so there's associated myocardial injury. So the problem is that there's lack of clear guidelines in management in this situation, because on the one hand, you want to treat the thromboembolism, and on the other hand, you want to reduce the hemorrhagic risk. Yeah? So it's really quite a difficult clinical situation. And we do know that this worst outcome because this patient actually has a higher morbidity and mortality. So I think it's important to manage the patient's risk factor. In this case, it's actually his hypertension. We think that what probably happened was that when he went frantically in search of his bag, his blood pressure probably went up, and that precipitated a plaque rupture, probably on the right coronary artery. And that probably caused an acute arrhythmic event, and also the high blood pressure would probably have led to his cerebral vascular accident. So we know that hypertension from the interstroke study is actually the most prevalent risk factor for stroke. And managing them for more intensively actually confers a greater benefit. This is the ESPRIT trial, which is a recent, very large randomized controlled trial in China, which involves more than 15,000 patients in the population, using a strategy of intensive versus the standard kind of blood pressure lowering. So they actually found that intensive blood pressure lowering of having an systolic blood pressure of less than 120 confers a better clinical outcome, yeah, in terms of better clinical cardiovascular outcome. And in terms of those who had actually stroke or TIA, from the meta-analysis of 10 randomized controlled trial, you see that the aggressive blood pressure lowering actually reduces the chance of having a recurrent stroke. And there's probably a bit of difference between the agents used. So in terms of amlodipine, it is found that superior to the other agent like beta blocker, ACE inhibitor, ARB, and also diuretics in terms of stroke reduction, as well as reducing cardiovascular event. So in terms of cholesterol, we know that we have to be very aggressive in this patient because it's really very high cardiovascular risk. And so we should aim for an LDL cholesterol of less than 1.4 or 55 milligrams per deciliter. But you would ask, this is an elderly patient, 83 years old. We don't really have a lot of data for this group of patients, in all the clinical trials. But if you pull them together, both statins and non-statins, including the PCSK9 inhibitor trials, you find that actually the efficacy of cholesterol lowering up to even as low as 1 millimoles per liter, you get actually more cardiovascular benefit. And there's really not much of trade-off because you don't have increased risk of cancer or what we are concerned about, which is hemorrhagic stroke. Okay, and from the MIRACLE trial, that atorvastatin reduces CV event, including stroke within 16 weeks in patients with ACS. And the benefits as early as 30 days, as you can see from the PROOF-IT trial. And from the SPARKLE, know that high-intensity statin in high-risk patients with prior stroke and TIA actually has a very good benefit in reducing recurrent stroke and cardiovascular event as well. So in summary, ladies and gentlemen, I think it's very important to manage, our high-risk patients very well, including our elderly patients, even those in, octogenarian, nonagenarian, because, with latest advances in medicine, they're actually living a longer and healthier lives. So I think we should really treat them very well to reduce the morbidity and mortality. Thank you very much.
Then we go to our final presentation. Dr. Mohammed Rashid Mubarak from Sri Lanka will discuss the complications where we have a patient that has high risk for cardiovascular disease, diabetes, and even impaired renal function. Please.
Good afternoon. I thank Beatrice for giving me this opportunity to present this case. This is the last case, and it doesn't mean that it is the least important case, but I think this will be the take-home message for all of you at the end of this section, and the Beatrice will be more happy to listen to this case. A blood pressure in lipids, chronic kidney disease. So these are not a complicated case as we discussed earlier, the last two. This is the most simple, straightforward case, day to day, what we see in our clinical practice. A 47-year-old businessman on regular follow-up with his primary care physician. He's a diabetic for 13 years, hypertension for 7 years, and he does his regular physical exercise, and he's a non-smoker and he doesn't take alcohol. So that's a simple, straightforward case. In examination, he looked well, BMI higher, blood pressure high, pulse, heart sounds normal, lungs clear, and basically not much complications to see in this case. Here, investigations. HbA1c 7.8, blood sugar uncontrolled. He has developed end-organ damage, there is albuminuria, and creatinine has gone up, and SGPT. So understanding the case, what treatment he is taking. He was on glycoside from his general practitioner, metformin, atorvastatin 10 milligram. I want you to see that atorvastatin. Nifedipine, it's a common drug used in primary care, and some fish oil capsules. People very happy to take these capsules. So his cholesterol doesn't look very exciting. You think it's not very high. As I discussed earlier, the total cholesterol is just 216. Triglyceride is high, HDL 36, and LDL cholesterol, there is the mistake in that. That is 138. Sorry about that. That's the printing. It is 138. 138, right? So when this case comes, 138, you remembered his treatment here. Considering this, he wasn't atorvastatin 10 milligram. So we were discussing usually our patients are on 10 milligram atorvastatin, 10 to 20 milligram atorvastatin. So which of the following statement is correct? You can answer this. According to ESC guidelines, this patient belongs to high-risk category for cardiovascular disease. In high-risk and very high-risk patients, the LDL cholesterol should be reduced by 50% from the baseline. The LDL target is 70, and chronic kidney disease not considered as a risk feature of ESC guidelines. So you have to correct statement. One statement is correct. You can vote no. (50-50). It's coming down. Right. The first answer, the B, is the correct answer. High risk, very high risk patients, the LDL should be reduced by 50% from the baseline, and the targets are less than 55 and less than 70 in high risk and very high risk patients. So ESC guideline belongs to high risk? No, this patient belongs to very high risk category patients because he has diabetic and end-organ damage, high risk. And LDL target in this patient is less than 70. No, it should be less than 55. And the kidney is considered as a feature. So that is just to highlight this. Next, go to the slide, please. Slide. Sorry. So when come to the ESC guidelines, just 2 words about the kidney disease. A severe CKD, EGFR 30 is considered as a very high risk. And if the moderate CKD, EGFR 30 to 59 is considered as a high risk category. So this patient is, to highlight that kidney disease is an important risk factor in the guidelines. It was shown earlier, and here we can see the very high risk 55, high risk 70, and moderate risk 100 and 160. And also I have put the non-HDL target. Usually the non-HDL target is plus 30 to the LDL target, 85, 100 and 130. In this case, we should also consider, in addition to the LDL, we should consider the non-HDL as also as a target in this patient, because this patient's triglycerides are high, and it is also should be considered. So this is the categories, very high risk and high risk categories, you will know that. And when you take the diabetics, important to know that diabetes, are we control the cholesterol in our diabetic patients? Are we really controlling these patients? We know that it is a high risk category of patients' diabetes. When you take the ESC guidelines, the risk category depends on the age of the patient, duration of the diabetes, and presence of other risk factors, and whether there are any target organ damage. These are the things they have considered in the assessing the risk. Earlier, the diabetic was considered as a coronary artery disease equivalent. Now it is not considered like that. It depends on these factors. So considering that if a diabetes is less than 50 years of age and the diabetic duration is less than 10 years, they fall into moderate risk. Moderate risk, less than 100 milligram is the target. If the diabetes goes for organ damage more than 10 years duration, without organ damage, 10 years, with or another risk factor, for example, hypertension, they fall into a high risk category. The target is 70. And our patient is diabetes with target organ damage and 3 other major risk factors or diabetes, it falls into very high risk, and the target is 55. So in this case, the target is 55 milligrams per deciliter, and the patient's LDL cholesterol is 138. So you have to reduce very much more than 50% and target 55%, 55 milligrams. So what of this incorrect statement? This patient, you can what, was undertreated with atorvastatin 10 milligram, clearly. Lipids are better managed by adding fenofibrate to this patient. You know these patients are on higher triglyceride. And atorvastatin 40 and ezetimibe 10 is required to reach the LDL target in these patients. Atorvastatin is preferred in chronic kidney disease. The incorrect one. So there is a mistake in that. Because when you go to that, the lipids are better managed by adding fenofibrate to this patient is wrong. We should not add fenofibrate. The patient is undertreated with atorvastatin. Yes. Atorvastatin is preferred in chronic kidney disease. That's okay. Correct. Atorvastatin 40 and ezetimibe 10 milligram is required in the reach the LDL target. So that should be the answer. Right? So the last one. Atorvastatin 10, 40 milligram and ezetimibe 10. We may need to reach the target because his LDL cholesterol is 138 and we have to bring it down to 55. Bring it down to 55. So more than 50% reduction and more. So there's a mistake in the sentence. Next. Next. So this patient, was LDL, that cholesterol was in 221. So this patient is presenting to a burning chest pain after dinner 2 days back. So it's a late presentation of inferior myocardial ischemia, late presentation. It comes after 2 days. Ejection fraction was 45% with infraposterior hypokinesia. Angiogram is showing severe triple vessel disease with left main disease. He undergoes coronary lipid lowering therapy with risk factor modification. So this is the angiogram. You can see on the right side, the left coronary system extensively diseased. This is how we see our patients with diabetic on the right side, and probably reperfused right system for the inferior MI. He is coming a late presentation. He undergoes CABG and undergoes in 2023, his lipid profile is that he was on atorvastatin 40 milligram and ezetimibe 10 milligram. And his LDL cholesterol now is 60 milligrams per deciliter, 60 milligram. SGPT, these are the things patient worry more than the LDL. They worry about the SGPT, worry about the CPK, creatinine 1.8, HbA1c 6.4. So this patient, now the patient is a secondary prevention, undergoes CABG, and his current LDL cholesterol is 60 milligram. So what are you going to do? The patient is now on atorvastatin 40 milligram and ezetimibe 10 milligram. So now, considering these reports, what will be your next action? What the patient is going to do for this patient? The last question. Reduce atorvastatin 20 milligram daily with ezetimibe 10. Are you going to reduce the atorvastatin? Are you going to continue the atorvastatin 40 with ezetimibe 10 milligram? Or are you going to increase the atorvastatin to 80 milligram? If you have listened to Professor Landsberg's yesterday's talk, you will consider this sentence. Continue atorvastatin 40 with ezetimibe 10 and consider adding bempedoic acid to this patient. This is a discussion point. There is no definite answer, but you can discuss this. All have understood Professor Landsberg's comments. And atorvastatin 80. So in this case, the LDL cholesterol was 60 milligram, just above the target, but still, this is an extensive disease, severe triple vessel disease. Surgeon has done some revascularization, but the events will be here. So in this case, we will have to aggressively treat and give the maximum amount to get the pleiotropic effect of the drug, and you make it 80 milligram and ezetimibe 10 milligram. That should be the correct answer. And the last one for discussion, the D, no one has answered. Another option is to give bempedoic acid, but statins are more important than adding bempedoic acid here because of the pleiotropic effect of the drug. And that will be the end of the case.
So thank you very much. I'm looking at the time, it's almost 12:30. The end of our party. I want to thank everybody for being here the whole day and being in a very interactive audience, and also the presenters of this last part of the morning. It was very illuminating. I mean, not very often do you get psychiatrists attending a cardiovascular prevention meeting. And I have to add one small bit of information for the psychiatrist, because there is quite a bit of data that statins are effective in reducing depressive symptoms. There have been randomized controlled clinical trials looking at Hamilton depression scores showing that they are giving you a little bit of an extra nudge. I mean, it's not a complete treatment, but it's something that could be sort of an additional feature in our whole portfolio of pleiotropic effects of statins. Of course, we have to thank Beatrice and the wonderful team that made everything possible, including with the Slido presentations, with my co-chairman. Please, thank you for being here today, and I'll give the microphone to you to give the final goodbye.
Goodbye. That's all. Have a safe trip back home.
Ladies and gentlemen, thank you for your participation for today's session. Let's take a short break for 10 minutes and please gather in this room again for closing. Thank you. Please come back after 5 minutes for closing. Thank you. Meanwhile, we would like to ask you, our delegates, to kindly take a few moments to do this small service. Thank you.